start without wasting more time. I welcome Dr. Rashmi Grover to start the proceedings.
West, everybody knows she is affiliated to Manipal Hospital as a pediatric cardiologist. She is proponent and author of Cardiac Disability Criteria and convener author of consensus document on ARF and RHT, multiple posts in IAP, multiple articles and books. Westcon.
Good morning everyone. Thank you for coming for these sessions, and my tenure is going to be over, but it was wonderful, and all of you actually sitting here contributed for a very good experience for me and for everyone. Thank you, Dr. Mridu. We have many works. So what interesting about the congenital heart disease is I'm sorry, I think my slides are wrong. So anyway, I will work on these slides only. I think my presentation is wrong. This is not the same. And the other one, Mira, this is my fault. Probably I have. Or somebody else can take over and I can correct my slides. जो next lecture है? Next lecture किसका है? Thank you.
We've had a rain break somewhere, so we'll just.
To solve a problem, a mathematical problem, we use certain equations, certain correlations, and arrive at a diagnosis. I have started my career in 2003 as a pediatric cardiologist, but at same time I started my charitable camps and also the public speaking. So it was because I belong to Madhya Pradesh, Riva, and I got a patient Eisenmenger, and I think it's a criminal to have a Eisenmenger child. So I started teaching pediatrician and tried to arrange money from them for them. So I was able to create a program which was known as Spandan, and then first thing came into mind, as a scientist, I was very much fascinated by echocardiography. So all of you sitting here will understand that echocardiography remains our attraction. We think everything is based on that. So I was the first one who started these kind of training session where you are. We were teaching how to use the ultrasound echocardiography for the knowing the congenital heart disease. But later I realized that unless, because in a peripheral setup, in most of the setup, if you are not in a dedicated cardiac setup, you are not having optimized probes, you are not having a good echo machine. So unless you have a preceding clinical evaluation, probably you will not know what exactly is diagnosis. So your brain is sensitized for a critical and non-critical situation, then probably without a echo machine you can arrive at certain diagnosis. So we know that at least the incidence prevalence of CSD is 1%. So every 100 child coming to you, one of them has some kind of congenital defect. We can simplify this, but which one? This is the issue. So one thing is that, like, we must know that before going to pregnancy, one has to look for a preconception care and the health of the mother and even father. So that will prevent the congenital heart disease, and that is the only way to prevent the congenital heart disease. We came out with a guideline in Indian pediatrics last year, but the secondary prophylaxis we can say is the fetal ultrasound, where you know exactly what is happening. Sometimes complicated defect, if they are detected before 24 weeks of gestation, we can go for a termination, that is a prophylaxis. Or we can arrange a tertiary care center where the delivery can be done, and the baby right from first minute of the life is under good care. And then if any intervention is needed, that intervention brings us best result. So that is very important. And one thing where you get a mother with the fetus congenital heart disease, so this is called as in utero transfer. So that is very important. So what is the building blocks of a evaluation of a patient with a congenital heart disease? History, pre-conception, what was the history, antenatal, birth history, neonatal period, how it was, if it is presenting in post-neonatal period, how was the infancy and the post-infancy period. And we must know that every disease has a different set of symptoms at the different age of life. A ventricular septal defect will present differently at the 1 week of life and 6 week of life and 7 month of life, 2 years of life. So we need to know exactly what has happened, how. So the building block are history, SpO2, clinical exam, and then X-ray, ECG, and echo. Echo is the last. And these previous blocks, if we can actually identify them and we go through with them with total honesty and open-mindedness, then probably we will be able to recognize a critical condition, which is the most important part, and that is why I am taking this lecture. Other modalities are also there whenever required. So we know what is a really normal cardiovascular system. So basic rule and anatomy and hemodynamic integrity is such that systemic venous blood, which is having around 60% saturation, should reach to morphological RV, and then pulmonary artery, and then lungs. And then pulmonary venous blood should come to morphological LV and must reach aorta and body, and there should not be any mixing, and all the valves and the vessels should not be obstructive. So this is very important. So first thing, whenever there is a wavering from this rule, you will know through the pulse oximeter. It is very important. Pulse oximeter will decide where is the saturation, because a newborn, often you can say that this newborn is blue, but for a newborn 20 gram hemoglobin, even 90%, 95 saturation, there will be some cyanosis, but it's a normal newborn. And in few of the cases where pulmonary arterial hypertension is there, then also you get a cyanotic newborn, and that is a situation where NICU is needed. So, but with basically drug dependent circulation, one maybe this is a drug dependent lung or drug dependent body. So whenever drug dependent body is there, there is a way out where you can recognize by taking the all 4 limbs saturation. So you know if there is a decline of the SpO2 more than 3%, you become suspicious that some circulation for the lower limb is happening through duct. So that is how you know. So that is there you have to actually be careful about evaluating primary pulmonary hypertension, but making a wrong diagnosis, but on the critical side or erring on the wrong side is not wrong. So this is very important. Then history taking, as I said, most important, the how baby cries. How is the consolability? A baby cries and becomes listless. That is very abnormal. So these are the things where we have to, and of course we know feeding difficulty. We know that the breastfeeding for the child is what? It is treadmill test. So if a child is a lactational failure, mother is saying you should be very careful. Recently I got a patient where 9-month-old, because of ARTI, cardiomegaly was noted, and when somebody actually did echo, it was severe MR plus 3 millimeter VSD. Now will you believe this diagnosis? So the thing is, when you say 3 millimeter VSD and a good pediatrician over there, you know 3 millimeter VSD will produce the kind of murmur that pediatrician is not going to miss. So that diagnosis is wrong. So what are the alternative diagnoses when you are getting a sick baby where a cardiologist is saying that there is a heart defect and saying the 3 millimeter VSD, it is there or not. So you know, you will decide that either it's not there or it is a very loud VSD. So these are the clinical finding. It is not the echo. Echo is erring. It is saying that a small VSD. It cannot be. For a small VSD, you get a loud murmur. So your clinical exam says that exactly it is either a small VSD or it's a sorry, it's not a VSD or it's a large VSD. So there's a lot of things in the algorithm. This is a differential sinuses. So CSD presents in 7 set of clinical features. One is congenital heart failure, and what is the congenital heart failure for the shunt lesion. That is the high output failure. So you are not expecting the myocardial dysfunction, you are expecting, and the pulmonary venous hypertension. Actually you are expecting a decreased blood flow to body because lungs are stealing it. There is a thief sitting there because you have a hole, you are not locking your doors properly. So that is the ASD-VSD PDA, where you get tachycardia and hepatomegaly, and you should look for hepatomegaly, not the jugular vein. And then cyanotic baby. So that is also may present with the heart failure. So cyanosis never rules out heart failure, right? Because they are the diseases who are the congenital heart disease, cyanotic heart disease, but they present with the heart failure. Then hypoxia, when you have a child with the cyanotic spell. Eisenmenger, where the silent chest and you have a very banging P2, and there is a history of a period where child was acyanotic. That is what I said. Different point of life is have a different set of symptoms. So breastfeeding, as I said, syncope and chest pain, always they suggest some kind of restrictive thing. Either restrictive cardiomyopathy or obstructive pulmonary valve, obstructive aortic stenosis, obstructive aorta, which we know as a coarctation of aorta. Arrhythmias can happen anywhere. They can happen without a congenital heart defect also, and shock, intractable shock, when your pulmonary circulation or systemic circulation is totally deprived of blood. So you can see that pulses are so important. Can you tell me 2 diseases which can be diagnosed only based on the pulses? Anybody? 2 diseases. Coarctation is one, and so carotid thread for the aortic stenosis. Okay, I am not talking about the aortic regurgitation. That may be, though it's so hyperdynamic that you can always recognize that. So this is very important. There are different type of pulses. I am not going to tell about that. Then coming to liver, hepatomegaly. It is so easy for a newborn, you have to palpate. And what are the diseases you can make out with the liver, hepatomegaly? If you are palpating liver, only palpating liver, and this is a pulsatile liver. So there is a tricuspid regurgitation going on, whatever region. Okay, even ASD MR will present a pulsating, because through ASD you are getting all pulsation over liver. Just a liver pulsation, is a TR going on, right? So color cyanosis, upper and lower limb is more blue, upper is less. This is a differential thing. Then if you just keep, palpation is very, very important in congenital heart disease. You just keep your hand, a very sick 14 years old, and you are just keeping hand, it feels like a purring of a cat. And what is it? It's a very serious condition. It's a ruptured sinus of Valsalva. So these are the things. So Epstein anomaly, if patient is presenting with the pre-syncope, syncope, cardiomegaly, congenital, if baby is presenting with the heart rate of 40, what congenital heart defect you can think about? So that is a corrected transposition, mostly present with the complete heart block up to age of 40 in 40% patients, and the heterotaxy syndrome. So these are the things we should know, that acyanotic heart disease and cyanotic heart disease, how they are classified. They are mostly classified based on the, I will not say visual cyanosis. We have to look for the pulse oximeter, and then we know. And the cyanotic heart disease, there is a saturation less than 95%. But this is not the hard and fast rule, because God has so many ways of presenting as a congenital heart disease. So a patient with the absolutely pulmonary atresia, having an anomalous origin of right pulmonary artery, you may have no loss of SpO2. But PO2 will tell you. So there are certain other things, but obviously for the general this thing that SpO2 less than 95%, we should look for the cyanotic heart. Whenever I am saying about any clinical thing, we are going to look for it. There may be answers which may really not match with our clinical assessments. It's okay. We should always be ready to accept defeat and go ahead and take the correct answers. Then aortic stenosis, pulmonary stenosis, coarctation of aorta, most important thing, Dr. Mridu said. Then PA pressure, pulmonary arterial hypertension is very important in congenital heart defect, because all shunt lesions cause pulmonary arterial hypertension when they are larger. So if they are not large, you are not going to do anything for that shunt lesion. One small AST, a small VST, very tiny PDA. If lung pressures are normal, heart size is normal, you are not going to give anything to these children. So pulmonary arterial hypertension is very dicey in the congenital heart defect. We should understand when a doctor says that it's a large VSD and pulmonary arterial hypertension, we go in panic. Pulmonary arterial hypertension. No, this is not that pulmonary arterial hypertension which we are going to treat with the children of health. Actually, this pulmonary hypertension is only reflection of the hemodynamics, because the lungs are totally exposed to systemic pressure, they are showing the hypertension. That is a systolic hypertension. Till the diastolic pressure, pulse pressure are going up and the pulse pressure is going down, coming up, then the thing is that this pulmonary blood flow is getting obstructive. So there we have to obstructive or restrictive, and then that is a very bad phase. And because of that I started all my program, and I really would say that no Eisenmenger should happen in our country, neither for the lack of diagnosis, nor lack of judgment, and nor lack of money. We should arrange money for that. So these are the few pictures. This is a chart which is saying you what is the difference between the ASD, VSD and PDA. So actually the time is less, so I am just showing few slides. And the most important thing is that, now see this. Is it a cyanotic baby? What is happening to the thoracoabdomen? You can have a thoracoabdominal excess movement, and also there is a hepatomegaly. So this is clear cut and sinus is not seen. So it's a kind of acyanotic heart disease with kind of heart failure. But what it could be? So because murmur is heard only, kind of diagnosis was made mitral regurgitation. Mitral regurgitation in a small 3-4 months child and having this kind of heart failure, do you believe it? Mitral regurgitation may happen, but it's very rare. So all those children who are presenting below 6 months of age with heart failure and pallid attack and the lack of growth, you should think about this ECG. Just do ECG. You just do ECG and such a important diagnosis is there. What is that? So you can see 1 and AVL. Remember this 1 and AVL. Never Q waves are so deep. So always remember these Q wave, and if it is there, think of anomalous origin of coronary artery from the pulmonary artery, and we have to then take patient immediately for the surgical intervention. So we need to know what is the critical, what is non-critical. Critical may be because of the congestive heart failure, because of the lack of supply, blood supply to the lungs, because of lack of blood supply to body, and in transposition of great arteries you get everything, but still because your desaturated blood is reaching to lung, and the saturated blood desaturated blood is reaching to body, and lungs are getting only saturated blood. So those circulation are happening like this. One is in different side. Unless you have a good mixing, you may not get any oxygen for the body. So this is highly desaturated child. No murmur, highly desaturated child. You can make diagnosis without echo of either transposition of great artery or pulmonary artery. It's a diagnosis without a patient presenting with it. 70% approximately saturation and nothing else, no sound. So you should think about two diagnoses. Which one is the third? So obstructed TAPUC. But obstructed TAPUC present very early, within 3 days, 4 days. So it is not there. We know that for cyanosis you should have certain level of hemoglobin. You should have, if you are having 10 gram hemoglobin, cyanosis will be visible at the 65%. So these are very important things. These are the one more thing I would like to that is the X-ray chest. Achha, this one also I want you should know. Achha, sounds हो सकते हैं.
वॉल्यूम आ सकती है.
Volume बढ़ाओ. 2 slides more. Sound.
उसमें वो जो वीडियो प्ले हो रहा है.
What is this happening? What is this? Huh? What is this? What is it called? Cardiac emergency? Cyanotic spell. Cyanotic spell. We should not miss it. Okay? And we should not try forcefully give oxygen. We have to keep baby in the mother's lap, make comfortable knee chest position on the lap, and then you may give the nebulized oxygen, you may give the other drug, that is what? You can give the even ketamine, even morphine. Morphine nowadays not very much preferred because there is a respiratory depression. So you can sedate child, calm down, right? The most important is you see what is the hemoglobin, and because the anemia precipitates cyanotic spell, and you give volume. So here you are not, or this is the last slide, situs abnormality. It's a clear good thing. If you are getting the apex of the heart will not love the liver, but will love the stomach bubble. Okay, so if they are on same side, it's fine. If they are in the opposite side, you think about the complex congenital heart disease. If you are not looking at stomach bubble, central liver, then also you think this is a complex defect, right? So this is how it is. So okay. So a sick cyanotic patient must be investigated for comorbidity before transfer, because presence of pneumonia or comorbidities often lead to bad outcome of intervention. VSD slide को आप भेजे नहीं, आप पहले उसका pneumonia ठीक कर दो. A sick cyanotic child ज़्यादा problem है, then you can send that child, if baby is not surviving, better be in a cardiac setup. Any patient transfer, and always start the prostaglandin, even if it is a TAPVC, not responding to prostaglandin is not going to be harmed. If any patient transferred to given a good case summary, ambulance must have resuscitation equipment, defibrillator, adenosine, amiodarone injection, a doctor beside. That's it. That is how you go for a transport. Thank you so much.
Ma'am, we have learned a lot from you, and I always see up to you, ma'am. It's a privilege for me. Earlier I said to chair this session.
So I just wished we had more time for this presentation. So this can inspire you for having a heart disease specialty, this thing, CME. Yeah.
We will be planning in next 2 months. I never actually did it as a IAP president, because we were having e-masters classes and many things. But only for us, for the IAP West Delhi, we will go for a CME. Preeti, be ready.
Questions if anyone wants to ask from me.
Thanks, ma'am, for an informative talk. Now I request speaker and chairpersons to kindly move for the felicitation at self-point. We move on to the next session, which is when to refer a child to ENT. The chairpersons for the session are Dr. Uttam Paul sir, Dr. Vibhavari Bhutani and Dr. Shubhra. Dr. Uttam Paul needs no introduction. Dr. Vibhavari Bhutani is an ENT consultant in Dr. Bhutani Eye and ENT Clinic, Rajori Garden, and Secretary IMA Westtown, and is a dynamic personality. Dr. Shubhra is a consultant pediatrician at Little Hearts Children Clinic, Dwarka. I request Dr. Vibhavri Bhutani to kindly introduce the speaker.
Thank you, Rashmi ma'am. So, Dr. Sumit Mrig is the director and unit head at Max Dwarka Hospital and Max Saket. He also has his own center, Sankalp ENT and Cochlear Implant at Dwarka. To be honest, Dr. Sumit Mrig is one of the best teachers and orators in ENT that we have. And since our PG days, we've been overly excited to see his lectures. So, yeah, it's a great privilege to be chairing your session, sir.
Thank you, Vibhavri, for that introduction. Thank you, chairpersons. First of all, my heartfelt gratitude to the organizing committee of IIP West Delhi to give me this opportunity to be here amongst you. In fact, I have become annual participant in this. It's not showing.
So very good morning to all of you, and thank you chairpersons for the lovely introduction. So the talk that I will be giving today will be on pediatric acute kidney injury, and will not be going to too much of you can say hi-fi science. So it will be like basically focusing on the updates as well as practice mantras for the pediatrician.
You should tell us when to refer to you, that's all.
How to manage also I'll tell you.
You don't want to listen.
So acute kidney injury, as we all know, and it accounts for almost 15 million cases in a year, and 85% of them are from the developing world. That means late pickup, late referral, and the outcomes also become poor, and out of which 1.7 million die. Mild AKIs, which can be early pickup and can be managed early at a basic setup also, accounts for almost 70 to 80% of the patients. So that is where the focus lies. Pick them up early. And AKI is seen in 3 to 5% of all hospitalized patients. And when we talk about ICU care, so it varies. The incidence varies. Like in case it's like a level 1 ICU. So there the you can say the incidence may be around about 10 to 20%. But if we are talking about tertiary care ICU, it may be almost 30 to 40%. If we talk about cardiac ICUs, it can go up to almost around about 40 to 60%. So depending on what kind of patients are there in the ICU, your incidence of AKI also changes. 30% of the critical AKIs will actually die. So that's why picking them early and managing them early is the key. And 25% of severe AKI may lead to CKD in the follow-up period. So in a study which was published in British Medical Journal in 2025, suggested that the mortality of AKI in the hospital was almost around 18%, and stage 1 AKI patients were almost like 8%, stage 2 was 13%, and stage 3 was 28%. So as we go up on the stage of AKI, the mortality also increases. Post-discharge mortality was as high as 7%, and it was in the range of 1 to 9 years post-discharge. So you have to also understand the fact that these children who have AKI have got better, have got discharged. They also need regular follow-ups because they can go downhill anytime in the post-op period, in the follow-up period. So the practice mantra here is, so why a pediatrician must recognize AKI? 1 in 4 hospitalized children develop AKI. 18% mortality in severe cases. Long-term CKD risk is always there after recovery, so follow-up is mandatory. So, but early recognition can change the outcomes altogether. So another study it found out that the incidence of AKI in centers that measured serum creatinine often means more than 5 times in an infant during the hospital stay, was they had picked up AKI almost you can say 41% as compared to centers which did not check serum creatinine regularly, that is less than 5 counts per infant during the hospital stay. So what does it tell you? That in the high risk individuals where you feel that the child may develop AKI, has not developed AKI as yet, if you are regress in checking the creatinines as well as the urine output, so you can pick up AKI early. So in case you do not pick up, the risk, you can say your pickup, if you do not do your creatinine, your pickup will be almost down by 50%. So it is 41% in the children whom it was checked more frequently compared to 22% where it was not checked that frequently. The incidence of AKI was similar in neonates and children, almost 30 to 26%, but the mortality was much higher in neonates, almost 10 times higher. So in neonates, you need to pick them up more earlier. And 37% of AKI would have actually been missed if urine output was not checked. So all your high risk patients, you need to check the creatinine more often and you need to keep a tab on the urine output. So coming to the AKI epidemiology in neonates as per the Awaken study, which was done across 24 NICUs across 4 countries, and it found that 30% of the infants admitted in the NICU had AKI. And higher mortality was seen, almost 10:1 as compared to those who did not have AKI. And the hospital stay also was slightly higher with the children who had AKI. So what is acute kidney injury? So it is an abrupt reduction in the kidney function characterized by a decrease in glomerular filtration rate, decrease in the urine output, and accumulation of nitrogenous waste products like urea and the creatinine. So initially the word given was acute renal failure, which has been changed to acute kidney injury. Now why is it done so? Because earlier you can say when the creatinine used to rise 1.5 or the baseline creatinine was 2, then only our antennas used to get highlighted, okay, that something has gone wrong with the kids' kidneys. But now, in case the creatinine has gone up by, you can say, 1.5 times the baseline. The creatinine was 0.5 as the baseline and now it is 0.8. That means the AKI is set in. So we'll not call it kidney failure per se, but then acute kidney injury is there, so that you can pick them up early, you get sensitized early. And it also helps in, you can say, making a consistent definition across all the countries for research perspective as well. So we have different, you can say, classifications for AKI, initially given by Rifle in 2002, then Akin in 2007, and finally what we follow is the KDIGO guidelines, which was given in 2012. So this is our basic guidelines what we follow for, you can say, staging of AKI in our day-to-day practice. The reason why it is done is because it also incorporates the neonatal part. So in case, when as per the KDIGO, when do we say stage 1 AKI? When the serum creatinine has increased to 1.5 to 1.9 times the baseline, or an abrupt rise of more than 0.3 milligram per deciliter of the creatinine from the baseline in the next 48 hours. Okay, so even a modest rise of 0.3 milligram percent makes the child into the stage 1 AKI. And similarly for stage 2 it is 2 to 3 times, and for stage 3 it is more than 3 times the baseline. And remember, it has the creatinine criteria and it also has the urine output criteria. And it is not creatinine and urine output, it is creatinine or urine output. So even if the urine output drops to less than 0.5 ml per kg per hour within, you can say, for a period of 6 hours, the child incorporates into the stage 1 AKI. Now, acute kidney injury is a part of a continuum of renal pathology, including acute kidney disease and chronic kidney disease. So, in case the child has an abrupt rise of the serum creatinine within, you can say, lasting for 7 days, so it falls under the category of acute kidney injury. But if it lasts from 7 days to 90 days, it is acute kidney disease. And from beyond 90 days, if the creatinine remains high, then this child is having chronic kidney disease. So that is how we define. Because why it is done like that is because a lot of times the children may come as pre-renal AKI, where you just give fluids, it's a functional AKI, and then with time the things improve. So this is like acute kidney injury, where even your follow-up may not be too stringent. But in case the creatinine continue to be on the higher side beyond 7 days, okay, like a child with hemolytic uremic syndrome or a glomerular nephritis or had an intrinsic AKI, or in an obstructive AKI because of maybe a post-urethral valve or something. So these children need more thorough follow-up on a regular basis. So now what is the practice mantra 2 for the pediatrician there? Think AKI, it's like a 3-6-12 rule. So think AKI when you see 3, that is a creatinine rise of more than 0.3 mg/% in 48 hours. The 6th part is urine output if it's less than 0.5 ml per kg per hour for 6 hours. The 12th part is any high risk patient by 12 hours of admission does not comes out of that high risk, then again start thinking about AKI, put them into the highest group, and then start searching for both the urine output part as well as the creatinine. You need to monitor them more often. So don't wait for obvious renal failure. Obvious renal failure means the urine output is totally shut down, the creatinine is 2, 3, and then only you start acting. So act fast. As you know, there's a lot of systemic consequences of AKI. So when the kidney gets hit, you may have problem with the brain, like there may be a uremic encephalopathy, okay, or because of the hypertensive encephalopathy. On the heart, there will be overload on the heart. The cardiac function may get compromised. Either there will be hypertension or there may be hypotension. In the gut, there is ischemia of the gut that may come up, and then it may have effects on the bone marrow. There may be a cytopenias, maybe there the marrow may get suppressed. On the liver, there will be hepatorenal syndrome, the albumin will go low, third spacing will start occurring, and in the lungs you may get fluid overloaded, and the patient may have a problem with like pulmonary edema or maybe develop pleural effusion. So if your kidney gets hit, all these organ systems also get hit because there's a lot of crosstalk happening between the kidney and the other organs, and it's vice versa is also true. If other organs get hit, the kidney also gets hit. Now to pick them up early, as we have the coronary angina, you can say this profile. So similar, we have a renal angina index as well. So in the coronary angina, what happens is if the patient comes with heart issues, you do your trop-I, trop-T, everything. In case the patient gets, you confirm the diagnosis of the patient as an MI, you start your interventions. So same goes with the renal angina index also. You check your high risk profile of the patient. If it falls into the high risk profile, then how do you define the high risk is? If the patient is in the ICU, 2, if there is a solid organ or stem cell transplantation, the patient is on vasoactive medication, the patient is on mechanical ventilation. So this incorporates the risk criteria. And in the injury criteria, the serum creatinine goes up by more than, more than 1 time to 1.5 times to more than 2 times. This incorporates the injury criteria. So the risk and the injury criteria are taken into account. The multiplication of the score is done. So you have another pointer. So if it is more than 8, then that means, so if it is more than 8, that means the patient falls into the risk of, you can say, developing an AKI. And this score's predictive value is as high as 86% sensitivity and 77% of specificity. So if you just do this bedside analysis, so you can predict that this child may be having a high risk of developing AKI. So same, in case the risk is there, you run your assessment, the cardiac output assessment, the AKI assessment, run your electrolytes panel as well as the creatinine, and in case it falls into the AKI, and then you start your therapeutic interventions. So the mantra here is when to worry, your risk stratification. So in high risk case scenarios, check the creatinine at admission as well as the urine output. ICU admissions, all the patients with sepsis and shock in the ICU have a high risk of developing AKI. Patients with post-cardiac surgery, multiple nephrotoxic medications, especially if more than 2 drugs in a single patient, burns, trauma, diarrhea with dehydration, and an underlying kidney disorder. So these are the patients who have a high risk of developing AKI. So in these patients, you need to check your creatinine and urine output more often. Now coming to the furosemide stress test. So what is furosemide stress test is? In case a patient has, you can say, oliguria, the urine output is not coming at all, and you suspect this patient may be having AKI, or the creatinine has slightly gone up. So in those patients, what you do is, you can give a furosemide of 1 to 1.5 mg per kg. If the urine output is more than 2 ml per kg in the next 2 hours, that means this is a functional oliguria. So after giving diuretic, the child has improved. Now you can continue your further fluid management easily. You can give adequate fluids as per maybe the Holiday-Seeger formula. Replace the urine output. Urine volume is an indicator of organ perfusion. That means your other organs are more or less preserved. So the risk profile goes down. But in case you have given a dose of furosemide and the urine output continues to be less than 2 ml per kg per hour, that means it is an intrinsic AKI. Now this is that high risk patient where the chance of going to stage 3 AKI, need for renal replacement therapies, or you can say need for the nephrology consult actually comes over, especially in these children. So there you need to optimize the liquid intake. You cannot just keep on giving fluids. Now you need to come down to the AKI regimen that I am supposed to give 400 ml per meter square and replace whatever are the, you can say the other insensible losses. So all those things need to be done. So this is the group where the risk profile increases. So a study from India has been done where they have found that if you do a furosemide stress test, the chances of you picking up a stage 3 AKI is almost to the tune of 89%. The chances of this child requiring some kind of kidney support therapy is 78%, and the death in this patient is almost as high as 56%. So a simple test can help you in predicting so many things. And if you add a urinary biomarker to it, NGAL or a PENG, then the predictability goes as high as 95% and above. So the practice mantra here is furosemide stress test differentiates between functional and intrinsic AKI. It's actually a treadmill test for the kidneys like we have for the heart. So when euvolemic patients with persistent oliguria are there, 1 to 1.5 mg per kg of furosemide can be given. More than 2 ml per kg per hour of urine output in 2 hours is functional AKI. Less than 2 ml per kg in 2 hours is intrinsic AKI, where you need to minimize the fluid. So this helps you when to initiate dialysis and when and how much fluids to give. So biomarkers we have already touched upon, but there are a lot of biomarkers that are available in the market. So some are functional biomarkers like creatinine, cystatin C and PENG, urinary biomarkers like TIM, and damage markers like NGAL and hepcidin, and IL-18 is also there. So a lot of markers are there, but usually most of the time they have been actually studied for cardiac patients. So as we can see here, like for cardiac surgery patient, the urinary NGAL, the cystatin C and the TIM has been studied, and it can help in predicting AKI in almost around 77% of the patients. Again, they are available, but usually not supposed to be used in your daily day-to-day practice, but they help in, first you have to risk stratify that these are my high-risk patients, although the creatinine would have risen up. So in your hospital setting, in your ICU setting is where we can actually use them, that which is the patient which will actually need renal replacement therapy or a nephrology consult. So coming to the fluids, the core of resuscitation algorithm. So 10 to 20 ml per kg of crystalloids can be given as fast as possible. You may repeat it twice, but keep a check on the overload part also. So if the child is developing fluid overload, pulmonary edema, you need to cut down the fluid. 5% albumin may be required in especially the patients who require substantial crystalloid inputs, okay, or those who are into the leaky phase, something like a dengue or a severe sepsis where SIRS is there, where leaks are too much. So there 5% albumin may be used, and later it is the fluids are guided as per the hemodynamic assessment. Amongst the vasopressors, norepinephrine is always your first choice, followed by, you can say, dobutamine bar, dopamine bar, your vasopressin, because all of them actually help in increasing the renal blood supplies. But norepinephrine is the first choice. So when a patient comes to you in your emergency and you are giving a lot of fluids to them, so initially is the resuscitation time where you pump in a lot of fluids. Then is the maintenance time where input output is, you can say, equalized and you maintain the patient. And then do not forget you need to de-resuscitate the patient as well, because whatever extra fluid has been given, that needs to be removed as well. So either with the help of diuretics or with the help of a renal replacement therapy or a dialysis. But this is again, not many residents are there. So this is what we actually focus when we are teaching. Because what happens is in the emergency, patient would have been pumped in a lot of fluid. He reaches the ICU. ICU, the first nephrology consult comes in that this patient is too much overloaded. The person comes and starts removing the fluid, and the patient again destabilizes. So pump in fluids, stabilize, and by day 2, day 3, now start removing the extra fluid. Because again there is a thin balance. So euvolumia can be maintained in these patients by giving 400 ml per meter square plus ongoing losses. So this can be done. Insensible losses is with the 10% dextrose, and the urine output is replaced by N/2 5% dextrose. So this is the ideal choice of fluid what we give for a patient who is in the ICU and has an AKI. And in case you give less fluid, you will have hypotension, tachycardia, tissue hyperperfusion and oliguria. In case you give more fluid, there will be hypertension, edema, congestion and decreased oxygenation or pulmonary edema. So you need to have that thin balance in between two. In case the patient is fluid overloaded and you actually need to cut down the fluids, remove the fluid, then target a weight loss of 0.5 to 1% daily. Not too much vigorous weight loss that I want to get rid of all the fluid within one day. It cannot never happen and the BPs will crash out. And it has been seen in multiple studies, a 6% increase in the odds of mortality is there for every 1% increase in the fluid overload. So 1% increase, 6% mortality increase. So this is a single predictor where for mortality in a patient in the ICU, irrespective whether the patient has AKI or not. So avoid fluid overload, and it also increases your chances of developing AKI in mechanical ventilation. 2. This high fluid overload increases the longer ICU stay, prolonged mechanical ventilation, more need for ECMO and the support therapies. Then fluid balance on day 3 was an independent risk factor for mortality. A negative fluid balance was associated with lower mortality. So that's why you given a lot of fluid that you want to give, and you need to de-resuscitate also, so that the net outcomes are there. Now coming to the loop diuretics, which is like favorite practice, that let us give some loop diuretics and see. So as I have told you, furosemide stress test is just one-time application of furosemide. If it works good enough, you can continue as well. But if it does not work and you keep on pumping a lot of furosemide with that, it's itself a nephrotoxic agent. Anyway, it's not going to work, and you're exposing the kid to more nephrotoxic medications. So hence it's not recommended that you continue using it unless it is active and you are getting that fluid out. So practice mantra here is fluid overload kills. So more than 10% fluid overload in a patient increases your mortality risk by 4 times. So avoid it. Fluid overload is calculated by daily fluid in minus fluid out upon admission weight into 100. So less than 5%. Now for the pediatrician, continue careful monitoring, and you can keep the patient in your wards as well. 5 to 10% restrict the fluids, consider diuretics if it works. If it is more than 10% of fluid overload, urgent nephrology consult is required so that the need for RRT can be assessed. Now drug stewardship is also required. Now once the creatinine goes up, AKI is there. Now risk of ATN is there with all these kind of nephrotoxic agents. So avoid using it in case you can, but in case you need to use it, like a child where you need vancomycin has to be given to save this patient, there you need to do the drug modification as per the GFR. So first is avoid, second is if in case still it is required, then you need to do the drug modification. So this was a Ninja software which was you can say made by one hospital, and then it was sent across, you can say, 9 centers across US. So what it used to do is a software which used to give alerts to the doctors who are there in the hospital in case the patient is on more than 3 nephrotoxic medications or aminoglycoside for more than 3 consecutive days. It just used to send up an alert that your patient is on so and so kind of therapy, so kindly recheck the advice. So what was found out was, if you just send an alert, there was 38% reduction in the nephrotoxin exposure and 25% fall in AKI. So just by giving an alert, so many things can happen. And on similar lines, a baby Ninja was also made, where the same software was used in NICU, and we got the similar results there. So you need to just be optimized, okay, that these are the nephrotoxic agents, let me change, especially in children who are at high risk or children who have developed AKI. So the practice mantra here is, for drug stewardship, stop immediately the NSAIDs, the ARBs like enalapril or you can say captopril in case the patient is getting. Aminoglycosides, avoid, but use it if life-saving. Dose adjustments have to be done. And as we have said, the Ninja protocol helped in decreasing the nephrotoxic exposure by almost 38%, so keep in mind. a simple thought process about nephrotoxic medication every time you go for your ward rounds may help you in decreasing the chances of AKI. So mantra 7 is the 3M approach: monitor, maintain and minimize. So what do you need to monitor? The daily creatinine in high-risk patients, strict IO charting, daily weights, because urine output is also important marker for AKI. Avoid holiday seeker formula in all patients with AKI. You need to optimize your fluid intake and maintain euvolemia. Target 0.5 to 1% body weight loss if overloaded. Balanced crystalloids are preferred over normal saline. Stop nephrotoxic agents. Dose adjustment for renally clear drugs. And single dose of aminoglycoside in case it is required, because one dose of aminoglycoside may actually last for 48 to 72 hours in a child with AKI. So, few words on nutrition. So, intake has to be 20 to 30 kilocalories per kg per day as per the calories. Avoid restricting proteins in children. So normally, as per adults, they say AKI is there, cut down the proteins. You are not supposed to cut down the proteins because the child is already into a catabolic phase. And administer proteins as per the RRT that is minimum. So if you are on a PD kind of RRT, your losses of protein will be much higher. So you need to optimize the proteins and optimize the micronutrients as well. So manage the complications which are there associated with AKI. Kidney replacement therapy, again for that the nephrology consult is required. But just remember, in case any of them is there and you can say the medicines are not working, the child is having resistant hyperkalemia or uremic manifestations, then dialysis needs to be done. So practice mantra, again when to call the nephrologist as you asked. Stage 2 to 3 AKI worsening trend, fluid overload of more than 10 to 15%, hyperkalemia more than 6.5, severe acidosis, altered sensorium, pre-existing CKD or a glomerular nephritis, then definitely they need to be called up. Again, as you see, the progression to CKD may there. The higher the stage, the higher the chances of developing CKD. So monitor the patients who are AKI survivors. So how to monitor? First visit, 3 months post-discharge, BP, urine analysis for proteinuria, creatinine, electrolytes, and keep calculating the EGFR. Risk stratification can be done. Stage 1 AKI, less risk of developing CKD. So a follow-up annually for 2 years. 2 to 3 to 6 monthly for 2 years and beyond. And children who require renal replacement therapy is actually a lifelong follow-up because they may develop CKD anytime. So 44% risk of CKD is there in children with AKI, and early detection does matter. So the last slide. So now the take-home message for again the pediatricians: recognize patients at risk, maintain the perfusion. Fluid overload is a predictor of mortality, so do not miss that. Reduce exposure to nephrotoxic drugs. Limited role of pharmacological interventions. A prompt renal replacement therapy determines the long-term outcomes of such patients, and AKI survivors do require long-term follow-up. So do not just acutely manage them and forget them off. And remember, AKI today is CKD tomorrow. So your vigilance saves the kidneys for future. Thank you.
Thanks, Dr. Khanna, for the informative.
That the furosemide has to be given only for initial phase. So for 24 to 48 hours, and then if there is a need of diuretic, are we supposed to go in for another option?
So basically what I showed was that in case the child is not passing urine and you have optimized the fluid intake. Yeah. So give single dose of furosemide. Remember it is 1 to 1.5 mg per kg. Never give 0.5 mg per kg. It will not going to work. 1 to 1.5 mg per kg, single dose. Urine output starts pouring. Now it's a functional oliguria, things are going to be smooth. You can continue using your diuretics as per the need. But in case there is no response, now don't start pumping diuretic, let me give a higher dose, let me try one more dose, it's not going to work. So there you may start your renal replacement therapy early. So it's like a challenge that you have done. Challenge works, continue. Challenge does not work, withdraw.
Thank you. Thanks, sir. Questions can be taken at tea time because we are running short of time. I invite Dr. Sumit Mrak for the next session, please. And the chairpersons, Dr. Shubham and Dr. Ashish Deryani and Dr. Vibhavri Bhutani, please speak.
Sorry, Vibhavri, to have you for a little longer time. Sorry, Dr. Uttam, we would love to have your feedback.
I request Dr. Vibhavri to kindly introduce Dr. Sumit.
Can I have it here? The presentation will be here? No?
It's working now, no?
Okay. Thank you and apologies. Sometimes too much of technology can also be, on the negative side of it. So probably the resolution. So it happens, I'll tell you because I'm an IT guy also. The wiring from here till there will not support the resolution of the Mac sometimes. It happens. Anyway, thank you, Chairperson, and I'm fortunate to head two departments, Max Smart Hospital Sake, where I'm heading as director and head now for the last 10 years. And I have my own center, Sankalp ENT Cough Implant Center, just opposite Max Hospital, Dwarka. And last 1.5 years, is it moving? Okay, so finally I have my own Mac which is working. Thank you to my team at Max Dwarka and Max Saket and Sankalp ENT Cough Implant Center. We have a very strong consultant, about 8 people in the team, and my team too. So I think we are talking about when to refer a patient or a child to ENT. I would say that my association with pediatricians goes a very long way, maybe 16 years of my practice, because I'm a cough implant surgeon. So I would say that the first point of contact for all my patients is a pediatrician. So I would say I have the best of camaraderie with the obstetrician and the pediatrician when a child is born. So when to refer a patient, I have broadly classified into categories like recurrent episodes of ASOMs, CSOMs, parents coming to you that in spite of everything, the child is not responding. Whenever the child is having medicines, he's fine, but the moment we stop the treatment, the child comes back with another episode. Child speech not develop as age appropriate. This could be because of frequent episodes of CSOM, frequent episodes of ASOM, serious otitis media, but it can be congenital as well. Suspected foreign body in the ear, nose and airway. Snoring and sleep apnea. Nasal bleed, unknown origin. Sometimes you have the bleeding from the littles area, but sometimes you have intractable bleeds. They keep on coming in young children and adolescent boys and girls. Hearing loss, newborn and childhood. Microtia and canal atresia. Post meningitis when OE fails and it's referred and BERA shows hearing loss. This is a very, very ominous sign. This is a medical emergency. In fact, nowadays, hearing loss in the pediatrics is called as a neurological emergency. All high-risk newborn babies for OE and failed OEs, recurrent JRP, juvenile recurrent parotitis. It's a very, very known entity now. It's a part of Sjogren's syndrome, and we do see a lot of these children. Child who is breathless at birth, you suspect choanal atresias, maybe unilateral, bilateral. Of course, bilateral is an emergency. Hoarseness and airway disorders, you suspect subglottic stenosis, children under long-term ventilation in the NICU-PICU, laryngeal papillomatosis. So we'll briefly touch each one of them very to the point, Chris, so that you know what to do. As you know that snoring and sleep apnea is not only a big problem in the world in the adult population, but the pediatrics department, I would say, we have been flooded with sleep apnea in the pediatric group. I have never operated so many coblation adenoid surgeries in the last 1 year than we have done. There are a lot of factors, of course, diet, pollution, allergy factors, and the AQI we live in, especially this part of the year. This is horrible. Now you see this child. Can I have some volume? Volume. This is the way the child sleeps at night. A video made by a parent. And volume. And every time the child wakes up, he is having a typical posture. If you see, if someone has noticed, the neck is extended. This is because it is the point where he would like to get some amount of air, and he's making this choking spells all the time. Nowadays, most of the times these kids are sleeping with the parents, but sometimes they are in their separate rooms and they don't come to know. The next thing you do in such people is you do X-ray, and you can see a big shadow. If you can see, if this works. Where is the pointer? Okay, can you see this big shadow? That's adenoid tissue. There is actually no space for this child to breathe. So most of the patients, sleep when you have got tonsils and adenoid tissue in the nasopharynx, which compromises the airway. Sleep study. sleep studies, level 2 sleep study has become a very important part of diagnosis and documentation in most of these children. If you see the AQI of the AHI of the child, 89.6. Obesity is on the very high rise, and I'm sure you're getting to see a lot of these children in your OPD every day. So all these children have to be monitored for sleep studies because they are probable sleep apneic patients. Now, how does adenoid affect a child? Recurrent sore throat, mouth breathing, snoring, earaches, decreased hearing, sleepiness during the days, poor concentration. So finally it starts to affect your academic performance. Malformed teeth because the palate goes up and the maxillofacial is restricted, and risk of future ear disease. Now if you see these children over a period of years, they develop fluid behind the drum, and the drum starts to get sucked in, and there is finally ear disease. Again, X-ray of 2 patients showing enlarged adenoids. There is hardly, the airway is very thin, and so what we do, all of us have been trained with the conventional, cobulation, with the conventional adenoid curettes. This is how we were trained at Maulana Azad Medical College, but now things have changed. We have something which is called as a cobulation technology. It's an endoscopic surgery. The old technique, the problem was, it's there rampant in the society, and people say that adenoids, once you get them removed, they come back. Of course, that was true with the previous era, but not with the new era. So, because the adenoid curette will not be able to take care of this part in the nasopharynx. Whereas if you see the picture here, the central part is absolutely, you can see the septum here, you can see the turbinates here, and there is proper airway. So that's a torch tuberous, and these bubbles are the opening of the eustachian tube into the nasopharynx. How the surgery is done? Of course, the surgery is done in general anesthesia. This is the position of the child, and this is how we do the surgery. Now I am showing full-blown adenoids, 50% adenoids removed. Look at the depth of the tissue, and this is full adenoid removal. The only complication in adenoid surgery is the anesthesia-related issues, because these children are never free from complete clearance of the chest, because they always suffer allergic bronchitis. There is always secretions. So you have to try and find that window where these children can get operated, so that would need a clearance by the pediatrician and the anesthetist. And that's the only risk factor, because they have a high chance of having bronchospasm when they come out of the anesthesia. Can you play the next video, please? So I will just show you how cobulation adenoid is done. See, it's a cobulation buoyant, it's a plasma based technique. There is no bleeding. I tell the patients the child can go to school the next day. There is no waiting time, there is no bleeding. See, the plasma is generated and it actually melts away the tissue. It takes about 25 to 30 minutes for me to do one surgery. We have done 160 adenoid surgeries in the last 6 months, both at Max Saket and Dwarka. This shows the number of problems with sleep apnea the children are coming, and as young as I have operated a child of an anesthetist at 11 months of age who used to just sit and sleep from Rohtak. Husband and wife both anesthetists, and they were not able to figure out what is happening. It's a daycare surgery, it is bloodless, it is painless, no recurrence, completely under vision, and the child is returned to school next day. Of course, when we do tonsil, the recovery time is a little more. See the pre-operative picture and see the post-operative picture. This will never come back, and I have operated almost more than 1400 adenoid tonsils in the last 15 years, and I have never ever done a revision of my case anytime. Now, myringotomy. You see, a child having hearing loss. Now, this hearing loss is a very important component in children less than 3 to 5 years of age, because maximum brain development happens at 2 years. The cognitive functions are very high. The child is learning so many words every day in his vocabulary. Even about 30 decibel of hearing loss is going to affect the speech outcome of a child. It's a flat audiogram. Can you just play the video? Now, along with adenoidectomy, we do a myringotomy. I never put gromate. Let me tell you, in the last 10 years, I have not even put a single gromate, because I have treated the cause. The cause is adenoid. Once we remove the adenoids, the eustachian tubes will have a two-way pathway. Before that, it has a one-way pathway. Just suck out the fluid And the moment you suck out the fluid, post-operatively, the child is going to get back to normal. Many ENT surgeons introduce grommet now. There is no need for grommet until unless there is ET dysfunction. If there is a eustachian tube dysfunction, then you need an external output. If there is no ET dysfunction, which is generally not there in children, if you have treated the cause adenoids, there is no need to put grommet. Can you play the video? See that child?
आपका अच्छा कौन सी क्लास में पढ़ती हो और कौन से स्कूल में? अच्छा ये बताओ अभी आपकी एडेनॉइड सर्जरी की है, आपको कैसी सांस आ रही है? अच्छा आ रही है। और हेयरिंग का इशू भी था ऑपरेशन से पहले, अब कैसा सुनाई दे रहा है?
अब नॉर्मल सुनाई दे रहा है
जैसे पहले सुनती थी।
This is post-op. 2 hours after recovery, the child on table when he comes back from the anesthesia, the parents say we have never seen the child being so comfortable, because adenoid surgery is like, you know, on table recovery. The fluid is out, the child is hearing well. The child still mouth breathing. So I saw this child few months back. The parents said they have undergone coblation surgery outside Delhi, but the child is still having problem. Can you play the video? See the turbinate hypertrophy because of allergy, because of AQI pollution. You know, this child, look at the bulkiness of the turbinate tissue, and when I entered the nasopharynx, see the part of the tissue which is left. Now, this is the tubal adenoid tissue which people leave because of risk of injury to the eustachian tube area. Now, you have to be very, very sure that these are lymphoid tissues. They will hypertrophy again back because of the irritants, because of the pollutant, because of the allergens. So the clearance has to be 90-95%. If a surgeon is leaving tubal adenoids, trust me, in 3 years it will come back. So what we did play the video. See, I am suctioning and these are the tubal adenoids. You can see the septum at the back. That is the septum in the center. That is the septum. This is the tubal adenoid. And this is the culprit that it will hypertrophy in the next 3 years. And this is full adenoidectomy. So I did a revision of this child, and you can see how complete removal was done. Now it's been 7 years. The child is absolutely okay. See coblation tonsil, absolutely bloodless, painless, not even one RBC. It takes about 10 minutes to do this. Nowadays we have gone from the extracapsular to intracapsular as a part of sleep apnea. Less than 5-year-old child, I don't remove tonsils. The parents are always skeptical. What about my child immunity? Of course, tonsil is not the only lymphoid tissue which is giving immunity. There are millions of lymphoid tissue in the posterior pharyngeal wall, in the palate, which give you immunity. But then, this is extracapsular, but nowadays we have gone intracapsular and sometimes hybrid also. So, when you should think about tonsillectomy, when a child is getting 5 to 6 episodes of recurrent tonsillitis documented, needing antibiotic, fever, loss of stool, you should ask them to get this surgery done. Loss of stool and pain requiring antibiotics. We have reduced, there are a lot of reductions in the number of tonsillectomies happening. We are doing as a part of sleep apnea treatment rather than as recurrent tonsillitis. Now, my second part is going to be when to refer a child for suspecting hearing loss. 2 brothers from Punjab, 1 year apart, 6 years and 7 years. The family took 3 years to realize that the child's speech is not there. Everybody in the family used to say, your father also spoke late, probably they will also start speaking late. They came from Punjab, both of them are cochlear implantees now. So child not responding to sound stimulus. Just one thing I tell you, when you get parents, when you are seeing the children, a small 1-year-old or 6 months, just ask the parents, whenever there is a sound in the house, do you think that your child is responding to it? Or I know that most of you get otoacoustic emissions now, but many places OEs are not done. Simple, the sound of a rattle, झुंझुना, क्या उससे बच्चा हिलता है जब वो सो रहा होता है? When a child is sleeping and something falls down, whether the child gets up with a startle response, this is the best indicator that the child is hearing. You don't need to do any test. If you are even in a village, you can notice that. Speech not developed even at 2 years. There is not even monosyllabi, bisyllabi. Please think something is wrong. Delayed cooing and babbling, child admitted with meningitis. We have a protocol at Max, Saket and Dwarka. Every child admitted with meningitis, on discharge, BERA has to be done. We are blessed to have Dr. Sunil Bhasin and Dr. Vikas Taneja, and we have 99% coverage of OE at Max Dwarka with now with a big gynae team here, almost 100-150 deliveries are happening every month. And 95 to 99% coverage of OE is done at our center, because we have to realize that hearing loss is a very complex game, and what we are looking at is the yellow part, which is the speech banana curve where all vowels and consonants lie. A child up till 5 years of age, the hearing has to be within this banana curve for him to develop speech. As we know, congenital deafness in India, every 4 out of 1,000 births are born deaf. Torch infections, pathological jaundice, neonatal infection. So I would say that as a pediatrician, your role is that all high-risk deliveries should be tagged. I'm not saying every delivery, it's impossible for all of us to do, but all high-risk deliveries in ICUs, neonatal infection, torch infection, jaundice, pathological jaundice, prolonged stay in ICU, renal toxic drugs, they have to be tagged and they have to be followed up with OE and BERA. OE screening program, simplest. Can I ask the audience sitting here, how many of you are getting OEs or checking OEs that their newborns have got OEs done? It has to be. We have to see the only way to treat deafness is to diagnose it at early age. What happens in our country is all our taxpayer money go for the government funding program, but the results are not there. Why? Because all children are coming late. 4 years, 6 years, and that is why we don't have outcomes. Simple BERA test. If OE failed, please get a BERA, and in BERA, as you can see in the left, you don't have any waveform, and this is when you plan this child for a cochlear implant surgery. A simple CT scan and MRI scan of the temporal bone, and you can see the nerve in the cochlea, in the brain, and you can see the cochlea here. You can see the cochlea here, and you can see the cochleovascular nerve here. Now, how a cochlear implant works.
How the nucleus cochlear implant system works. The nucleus cochlear implant system is designed to mimic the functions of the human ear. Sound travels to your ear and the sound processor, which sits behind the ear. The microphones on the sound processor pick up sounds, and the processor converts them into digital information. This information is transferred through the coil to the implant just under the skin. The implant sends digital sound signals down the electrode into the cochlea. The hearing nerve fibers in the cochlea pick up the signals and send them to the brain, which is translated as the sound you hear. Unlike a hearing aid that simply amplifies sound, cochlear implants send sound directly to the hearing nerve and on to the brain.
So a cochlear implant is a bionic sense organ, and every child who is born deaf, a child who becomes deaf because of infections, adolescent, post-tuberculosis, post-dialysis, trauma, accidents, sudden hearing losses, they are candidates for this. The most important in cochlear implant is the OT setup. This is the setup at Max Dwarka. We have completed 40 cochlear implants in the last 1 year since the hospital has got commissioned, and we have great support from our pediatric team, for our anesthesia team, and a cochlear implant surgery is generally a mastoid surgery. So all ear surgeons who do ear surgery, but the important part is handling of the device. So you drill a cortical mastectomy. Through the cortical mastectomy, you enter the middle ear and then you go in the inner ear. I'm not going into the details of it, but then this is how the post-op day 2 looks. Now, everywhere across the world, there is early switch on. Early we used to switch on at 4 weeks. 3rd day, we put the processor on the child ear and the child starts hearing. Setup for aided audiograms. Video play karenge. You can see the child hearing is within the normal. This is a post-cochlear implant. Absolutely normal bilateral, going to normal school. You can see the hearing. It is normal hearing like you and me and have. Let me tell you, when we grow, adult population will have far better hearing because of their implant than what you and me are having. They will be able to listen everything and we will struggle because of our natural. So these are all the implantees, bilateral, switch on AVT. Second wala video play karenge. So there are more than 700 patients.
1.
Normal speech. He is undergoing therapy.
2.
प्ले करें, लास्ट वाला।
आप मुझे जॉनी जॉनी वाली राइम सुनाओगे? ओके चलो सुनाओ। जॉनी जॉनी।
Normal speech.
Yes, Papa.
What you and me speak.
Mom.
Simultaneous implants. ये second video play करें ऊपर वाला. Give me 3 minutes. I'll just finish it. ऊपर वाला video play करें.
Start. नमस्कार, हैप्पी रिपब्लिक डे टू ऑल। देश मेरे देश तेरा कितना प्यारा नाम है, कितना प्यारा नाम है, हमें घर बैठ छुपा तेरे झंडे को सर।
So you see, a child born deaf, at 2 years of age, the family got bilateral implant. She is in class 6 now, going to a normal school, talking normally, rhymes, poems, because early implantation, early intervention.
Re-implantation has to be done as the child grows?
No, it is once for lifetime. You just change the outer machine, the processor. Once you get an upgrade for that, maybe after 6 years, 7 years or 10 years, the inside implant stays like that. Now I'm going to talk about something, juvenile recurrent parotitis. How many of you see children less than 4 years, 6 years, 8 years with recurrent parotid swelling? We might be missing something which is called as JRP. It's a very common thing. It could be part of a Sjogren syndrome, especially with fever. The swellings will come and go. And we have to diagnose, and nowadays we are doing regular endoscopy for these children. We have a miniature telescope which is 1.3 mm. The only thing you do in such children is you dilate the stensons or the Wharton duct, you just give corticosteroid washes and you flush it. Flushing will help you in stopping the progression of the disease, because inflammation of the duct will lead to strictures sooner or later. And finally they will have sialosyl formations, they will have duct ectasias, they will have blockage, they will come with permanent swellings of the parotid gland. So you manage the part of the Sjogren syndrome with, it's an autoimmune condition, but 1 or 2 times in a year these children require steroid washes and flushes. We have a complete setup. We do it in all adults and pediatric population. That's the endoscopy. Can you play the video? So you go through dilatation of the stensons and Wharton duct, and you can go inside the duct and see. Is it playing? Okay. External aortic canal atresia, very common as a congenital anomaly. The child was operated. Since it was a soft tissue atresia, the chances of facial nerve weakness is always there. So I always use a facial nerve monitor. Then microtia with congenital cholesteatoma. The child doesn't have a pinna. We do Baha implant in such patients. And if you do the CT scan of these children, there is a huge mass sitting in the mastoid antrum. And the most important is you operate these children but use a facial nerve monitor, because microtia, the facial nerve can be superficial. Do the BERA testing. Mind you, in microtia or anotia, you need to do a bone conduction BERA. So most of the clinics will not have a bone conduction BERA, because what we do is an air conduction BERA. So you can send these children, refer to ENTs. Then unilateral choanal atresia. I'll just show you an interesting case. The child got away after the birth because there was unilateral atresia. Can you see this bone, a white bone? Just see, there is canalization of this aperture, the posterior choana, but this side it's a blockage. Can you play the video? Both you can play. See, I have removed the adenoids. We have gone till the floor, and I have done recanalization of the right side of the choanal atresia. 2.5 centimeters. It was not a medical emergency or surgical emergency, because the one side of the nostril was open. But the child came and we detected unilateral choanal atresia. Now you can see the adenoids are gone, and so is the choanal atresia component. So always watch out for children whether they have any feeling of blockage or they feel that from one side of the nose the secretions cannot drop down. Congenital cholesteatoma, facial palsy. Child walked into my OPD with a congenital facial palsy, did the endoscopy and saw this white marsh behind the drum. Got the CT scan done and we operated him for a cholesteatoma. Epistaxis. A child 12 to 14 years of age, epistaxis was not stopping. Got the scans, what we got was angiofibroma. Just play this video. So, little bit of blood loss can be okay from the littles area, but sometimes there is a big mass which is hovering, and don't miss that. Refer these children for a nasal endoscopy. You can see this is medial maxillectomy, all endoscopic. We don't do any external incisions now, external removal, everything is endoscopic. You can see the area of the carotids here. Finally, sudden onset eye swelling. I got this child 1 or 2 years back. Sudden onset preseptal orbital cellulitis. You can see the MRI, T2 weighted enhancement, and the child could lose the vision. Play both the videos. Just deroof the lamina papracia and remove the pus, and the child improved with IV antibiotics. So don't delay. This can be sinister for a small child because the optic nerve is just right here. Optic nerve is just right here. It will start impinging on this. So there is a pus which is being released. I think last slide I have, one more slide. Yeah, laryngomalacia. Just play the first video. That's my last slide. Maybe a second last. The child is born with noisy breathing and stridor. This is a laryngomalacia. Can you play the first? Yeah. Play. Beautiful videos of different types of laryngomalacia. Can you play the last video? Just cold steel release of aryepiglottic fold, and the child sleeps absolutely quietly. The parents were, yeah, just see. This was playing. Just play the last video, if it can play. The same child is sleeping well under the cover of oxygen. So laryngomalacia can also be treated like an emergency, and if you are not finding any gain, then please send. Papillomatosis, child with hoarseness, we do removal of the tissue with the help of laser. Can you just play the video? See, extensive papillomatosis which is blocking the airway. Of course, we did family income below 7 lakhs annually, a child less than 3 years, we provide them with free cochlear implant. They only have to pay 1,65,000. Apart from this, the expense is 7 lakh rupees for the implant, which the trust provides free of cost. Only we check the documents, the data and everything, and we have done close to 40 to 50 cochlear implants under the trust in the last 3 years. And the numbers goes on, more than 700 implant everywhere in the country, mentoring about 14 centers across the world. And thank you so much for a patient listening, and I appreciate a good audience on Sunday. Thank you.
Thank you, sir, for an excellent talk. What is the age appropriate for cochlear implant? What is the oldest patient you have done, and what is the experience of the results?
So a child who is born deaf, prelingual deaf, the best age to implant is 11 months. We are doing day in and day out. But in our country, the age varies from 2 to 5 years of age because of late detection, late identification. They keep on trying a lot of alternate modes of treatment. But generally, 2 to 5 years. But we are trying now, there is too much of awareness about it. And we are getting these children referred by our pediatric colleagues. So if a child is using hearing aids, undergoing speech therapy, even I have done up till 6 years, 7 years. But these are convert candidates. So early intervention is important. They might not have the money, but then if they have put their child with speech therapy and with hearing aids, some stimulus is going on and we can do such children. But ideally, I'll tell you, best outcomes with mainstream education in school, I can promise, is less than 2 years. Beyond 2 years, they will start hearing, they will speak words, they will speak phrases, 1 or 2, but sentences will be an issue. Continuous sentences like I am talking. Otherwise, we have patients who are talking like you and me are talking. Yes.
Sometimes after adenoidectomy, most of the parents complain still the child is having mouth open.
I showed that. So I told you the reason.
So
you have to train the brain.
Deal with it?
You have to train the brain. The child is sleeping with open mouth for the last 5 years, 10 years. Okay. Now the brain doesn't know that you have to breathe from nose. So what I do, so I'll tell you, ask the parents to use a hanky, put it in the mouth, clench between the teeth and ask the child to run. You have to force him to use his nostrils to breathe. Number 1. Number 2, all of these end up visiting the oral maxillofacial or a orthodontist because the maxilla has to be expanded and come back to normal. Okay. But that's a very valid point. Change in voice and still continuing to breathe from mouth are the two problems the parents talk to me. So I always tell them, your child never knew how to breathe from the nose, number 1. he was never speaking from the nose, he was always speaking from the oral cavity. That's why the change in voice happens.
Thank you, sir. Another thing we need an early referral for is noise-induced hearing loss.
Yeah,
Nowadays
I
it's
did
becoming
not
a
mention
great
that
issue.
because that was not in the field of the pediatrics. But yes, NIHL, it's a neurological emergency. I cannot tell you, we have just published a paper of about last 5 years since COVID, 1,480 patients with sudden onset and noise-induced hearing loss. And we have a publication which has been accepted. So maybe next time when I'm here, I'll just show you the data. There are multiple reason causes: poor diet, nutrition, noise pollution, headphones, disco, dance music, viral infections, idiopathic, COVID, everything is included.
Yeah, concerts and headphones are really
Yes,
an issue
yes.
nowadays.
And India is a land of concerts now, let me tell
Yeah,
you.
and we only have a period for like 3 days to 7 days to actually give result in a
Yes.
patient. So if everything is not waxed every time you have hearing issue, so if you have ringing in the ear, please get an ENT assessment as early as possible.
If any parent comes to you and says that my child was not complaining, and mainly I'll tell you, if it's a unilateral loss, the child will never complain. Because for a child to have that cognitive function to diagnose that I'm hearing until unless he's using a telephone or a mobile phone and he's around 10, 12, so a teenage boy or girl will identify, but not a 4-year-old, not a 5-year-old. The parents will have to notice that when I'm talking from either of the sides, from one side the responses are poor. So maybe they have to pick it up, and it's like an emergency within 24 to 48 hours that needs treatment. Thank you. Thank you very much.
Thanks for a wonderful talk, sir. I request all the chairperson and speaker to be at selfie point for the felicitation, and we move on to the next topic, which is tiny clues in tender skin. I request chairpersons Dr. Sunil Solanki, Dr. Dinesh Goyal and Dr. Anita Pandit to be on the stage, and Dr. Sumit Sethi as a speaker. Dr. Sunil Solanki is HOD Pediatrics at Dadadev Hospital. Dr. Dinesh Goyal, Senior Consultant Neonatologist at Mata Janan Devi Hospital and Secretary-elect IAP Delhi. Dr. Anita Pandit, she is HOD Pediatrics in Guru Gobind Singh Hospital. I request Dr. Dinesh Goyal to kindly introduce the speaker.
Very good morning to all of you and welcome in this Westcon 2025. For this session, I would like to invite Dr. Sumit Sethi. He is a renowned dermatologist in Janakpuri area and he is running a Derma Station Skin Clinic in Janakpuri. And he was the observership in the pediatric dermatology at Mounts in the United States. Now, I would like to invite Dr. Sumit Sethi, sir, please.
Good morning, everyone. My topic today is tiny clues in tender skin. These are small skin signs, offer important clues for the diagnosing pediatric conditions. Recognizing subtle features aids in early diagnosis and accurate diagnosis. So what I could understand from the topic is, I'll show pictures, I'll give you clues, you tell me the diagnosis, and then we'll discuss management. So a small child, ununate, yellow greasy scales predominantly over scalp frontal vertex areas, non-itchy, asymptomatic, most common presentation between the ages of 4 and 16 weeks. Anyone with the diagnosis? Cradle cap. Diagnosis is seborrhea and cradle cap. Management is emollients and mild shampoos. In addition to the redness that we saw in the earlier slide, in this patient, the involvement is there on the forehead, on the eyebrows, as well as on the seborrheic area of the face. The child is healthy, often above the medial centile for age, and rarely symptomatic. Diagnosis. This is slightly different from the previous slide. The earlier involvement was just on the scalp, and this is involving the flexures as well as the face. Seborrheic dermatitis. Yes. When the dermatitis involves the face and body areas, including the joints and flexures, we call it dermatitis. The differential diagnoses include, in the flexures, irritant dermatitis, atopic eczema, and the severe involvement of Langerhans cell histiocytosis. Now, patient presenting with facial hypopigmentation. ill-defined hypopigmented macules and patches with mild scaling, most evident on the cheeks of children. These are rough to touch, asymptomatic. Diagnosis. PL bar. Diagnosis is clinical. The lesions show fine scales, no significant melanocyte loss. Wood's line examination shows no enhancement of hypopigmentation. Usually when the patient presents, the erythema is gone, the scaling is gone. What we see is just hypopigmentation with smooth skin. Treatment is emollients. In case of scaling and erythema, we give a short course of mild steroids and continue with emollients till the patient gets its pigmentation back. That is usually between the 3 to 6 months post this. How does this happen? There is impaired transfer of melanin to the keratinocytes. So this is a differential diagnosis. A stable hypopigmented patch which is present since birth and sometimes presents before 3 years of age. Size only grows in proportion to the child's growth. Diagnosis. Anyone with the diagnosis? Most commonly presents at birth or before 3 years of age, often single patch on the trunk, hypopigmented, feathery margins, doesn't increase in size, doesn't change in appearance till adulthood.
Could be birthmark?
Birthmark, nevus depigmentosis, yes sir. Again, this is a larger nevus depigmentosis, feathery margins present on the trunk. This is P versicle. Autoimmune condition present in children presenting between 20 to 30 years of age most commonly, associated with other autoimmune disorders. Lesions are chalky white and complete loss of melanin in the lesions. Vitiligo. Patients presenting with hair loss, patchy hair loss, non-inflammatory, sometimes with scaling, sometimes with black dot sign. The hairs break at the surface of the scalp. Can be single or multifocal. This is not here. No sir. Close, very close. There is inflammation involved. Areata is non-inflammatory. The diagnosis is by scaling and inflammation, and sometimes we get cervical lymphadenopathy also. This is another presentation. Patches of partial alopecia, often circular or oval in shape, numerous broken off hairs, dull grey from the coating of spores. Inflammation is minimal, fine scaling is characteristic, and there is fluorescence under Wood's light. This is tinea capitis. Boggy swelling on the child's scalp, tender plaque, pus and broken hairs, severe inflammation, cervical lymphadenopathy. The lesion is very much less painful than the appearance suggests, most commonly diagnosed as abscess. A painful inflammatory mass, very less tender, hairs are very loose, follicles may be seen discharging pus. So this is the severe form of tinea capitis known as chirion. The differential diagnosis of these tinea capitis and chirion include alopecia areata, tractional alopecia, trichotillomania, and seborrheic dermatitis. Tinea capitis, also known as ringworm of the scalp. The spores of ringworm fungi cause tinea capitis are demonstrated in close proximity of patients with the condition. The clinical appearance of ringworm of the scalp is variable depending on the type of hair invasion, the level of host resistance, and the degree of inflammatory response. Cardinal features are hair loss with inflammation to some degree. If untreated, it may become chronic. Spontaneous recovery usually occurs at puberty. We diagnose in OPD using dermoscopy, which shows presence of comma and corkscrew shaped hairs. Microscopy, culture, and PCR can be done in hospital-based practice. Management. Exclusion of children from school is not recommended. Patients may not complete treatment if we advise exclusion from school. Ketoconazole shampoos and selenium sulfide prevent spread to other children. Terbinafine is given in cases of trichophyton, and griseofulvin is given in cases of microsporum infection. In severely inflammatory forms like we saw in chirion, oral steroids can be given to prevent hair loss. These are well-defined, smooth, round oval patches of hair loss. Exclamation mark sign is seen on trichoscopy. It's an autoimmune disease causing hair loss. Small round patches on hair loss on body. Anyone with diagnosis? alopecia areata. This is a congenital, non-scarring form of hair loss which closely resembles alopecia areata. Seen since birth, usually small, vellus, very tiny hairs are seen. It's present on the frontotemporal region. It's temporal triangular alopecia. This is again present in school-going children. Hair loss across the hairline, most commonly seen in children with tight braids. This is tractional alopecia. Now again, a small child present with erosions, vesicles, pustules around mouth and nose, along with golden brown crusts. The child is usually asymptomatic. These crusts and lesions are slightly tender to touch. Impetigo. Blisters rupture, ooze and form a yellowish honey-colored crust over the yellowish area. This spread by scratching, caused by staph, aureus and streptococcus pyogenes. This is impetigo contagiosa. Peripheral spread of crusting leads to central erythematous skin and erosions. The focus of staph is in the nostrils. Fragile blisters, golden yellow crusting, peripheral spread. The blisters keep on spreading in the periphery and the erosions, raw erosions in the center. Anyone with a diagnosis? Very close to impetigo. It's bullous impetigo, again caused by staph and strep. Differential diagnosis of the above condition is immunobullous diseases, localized staphylococcus skin syndrome, contact dermatitis and herpes simplex. Impetigo is a contagious superficial pyogenic infection of the skin. Two main clinical forms are recognized: impetigo contagiosa and bullous impetigo. Causative organisms are staph aureus and streptococcus pyogenes. Overcrowding, poor hygiene and existing skin disease, they predispose to the infection. Predisposing factors also include insect bites, pediculosis, scabies and minor trauma. Treatment is frequent application of ointment, preferably mupirocin, in case the lesions are very small and localized. In case the impetigo is extensive, there is lymphadenopathy, the child is asymptomatic, then oral antibiotics are given for a week. This is a differential diagnosis of impetigo. Child presenting with small grouped vesicles on an erythematous base, and they heal with varioliform scarring. The mother gives a history of recurrence in the same region after any fever or upper respiratory tract infection. Anyone with a differential diagnosis? Inoculation herpes simplex. Recurrent herpes labialis may need no treatment if the attacks are mild or infrequent. More troublesome recurrences or associated with scarring, they merit antiviral treatment with either acyclovir, valcyclovir or famciclovir. Recurrences of herpes labialis may be prevented or reduced in its intensity by the use of a topical sunscreen. Raised white bumps. Shiny hemispherical papules with central umbilication, spread by autoinoculation by scratching. Umbilicated lesions, yes, molluscum. Umbilicated lesions are different stages of evolution. Giant umbilicated or a solitary lesion. Sometimes may get an inflammatory response, which is due to discharge of molluscum contents into the dermis rather than by secondary infection. If there is molluscum dermatitis like this, it's managed by giving steroids, not antibiotics. Differential is sebaceous hyperplasia and plain warts. Most cases of molluscum are self-limiting. They may go on their own by 6 to 9 months of age. Individual lesions are unlikely to persist for more than 2 months, but some lesions, particularly if solitary, may last up to 5 years also. Perilesional inflammatory responses, once they start in molluscum contagiosum, it's a very good sign and it denotes the presence of immunity against the molluscum infection, so called the beginning of the end sign. In many instances, we counsel the parents that treatment is not necessary. Depending on personal preference and severity of infection, the treatment may be provided. Treatment may be provided if the lesions are symptomatic or if the clearance is slow. The choice of treatment will depend on the age, presentation, as well as the preference of the child and caregivers. There is a FDA approved treatment now for molluscum. It's not available in India, but Badazymer gel, which is a nitric oxide synthetase gel, is available. This is a hypersensitivity reaction to insect bites, usually occurring as crops of more or less symmetrically distributed itchy papules, papular vesicles, most frequently on the exposed areas of the extremities, often heavily excoriated, and tends to occur after monsoon and winters. We see such children in pediatric OPDs, parents coming with itching on the arms and legs, most commonly seen below the elbows, below the knees. It's papular urticaria. It's an insect bite hypersensitivity reaction. The elapsed time between an insect bite and the formation of a firm, intensely itching papule begins to lengthen as the children get used to insect bites, which makes it difficult for us to explain to the parents that these lesions are insect bite hypersensitivity only. Condition is only controlled if insect bites can be prevented. Full sleeves clothing, mosquito repellent and mosquito nets are advised during the season. Children eventually outgrow this disease probably through desensitization after multiple arthropod exposure. So this is a very classic sign that we see. Intensely itchy child, itching all over the body, this scabies. The first one shows burrows between the interdigital spaces. The other one shows inflammatory papules or nodules in the flexural areas. The child complains of intense itching mostly at night, and the classical lesion is burrow between the interdigital space and genital nodules. Treatment is permethrin and with ivermectin. The last one. A child with eczematous lesions on the face associated with intense scaling and pruritus. Atopic dermatitis. Early recognition of tiny clues is crucial for the timely pediatric dermatology diagnosis, clinical observation, basic lab test, and history guide management. Thank you.
Thank you, Dr. Sumit. Dermatology and common conditions. Thank you for sharing. Any questions from the audience side? Any special case if you want to ask? Because yes, sir.
Approach the herpes labialis, whether you give the topical acyclovir or oral, severe versus mild, how do you go about it?
Sir, if herpes labialis is leading to scarring and the lesions are very much frequent, more than 6 times in a year, then I prefer to give oral. Sometimes herpes labialis can cause...
How long would it be?
Sir, for 5 to 7 days.
No, that is for therapy. If
Yes.
you have to give for prophylaxis, that is for almost 3 months.
Sir, acyclovir is approved for prophylaxis up to...
If you have recurrent for more than 6 episodes, then 5 doses would not help.
Sir, acyclovir is approved for continuous usage for up to 7 years. Continuous 7 years. We can give prophylaxis. Continuously 7 years, continuously we can give acyclovir.
Any role of topical acyclovir in mild herpes labialis?
No. No role at all. Doesn't help in early healing. Doesn't help in lesion prevention.
And first episode, severe lesions, any role of oral acyclovir?
First episode, oral acyclovir should be started within 48 hours, then it has a role. After 48 hours, no role.
Thank you.
Any other question? Yes, Dr. Raman ma'am.
Stress and diet. Ma'am, diet sometimes iron deficiency, vitamin D deficiency, they have been seen related to hair loss, especially in females, not in males. Stress can cause temporary hair loss, which is known as telogen hair loss. Any kind of acute stress, maybe death in the family, any accident after a particular surgery, like we talked about surgeries earlier, adenoid surgery, tonsillar surgery, that can lead to acute hair fall post 2 or 3 months post surgery. That will continue for 3 months and it will recover on its own.
Thank you, Dr. Sumit.
Thank you.
I think we are running short also. Thank you so much.
Using it, SEO, website growth, CRM, automation. Anybody knows what is the CRM in the house and what is the SEO? Just to start us. Search engine optimization. Yes, sir. And what is the CRM? Excellent. So some of you are informed, and that's very good because we have to advance this age. This is not the age of having a standalone practice and doing nothing and thinking that patients will come to you on their own with your word of mouth only. because we are in the world of highly competitive, people with a lot of corporates and who have invested heavily in creating their online presence, sometimes even misusing that also. Make him more informed, and also the patient has a portal where he can log in and has easy access to his own health records, his prescriptions, his follow-ups, his reminders, his growth charts, and other miscellaneous informations. And it creates a trust, your clinic brand, your doctor's brand, a confidence. It reduces the manual labor and the clutter. So, and better data management, storage analysis. We will touch on data management because this is pretty serious topic these days. And what are the benefits? It is, as I said, marketing and SEO can also be used. We can use AI tools for marketing and for more interaction with our unknown customers. So, as I always say, we should regard the patients as customers and we are the vendors. It's not that dilution of ethics is there, it is just how the things work in the business world. So even if you are working somewhere, your own practice or even a nursing home, you are technically covered by Consumer Protection Act. So once they are the consumers and you are the vendors. But we have other responsibilities for being doctors, so we have to maintain ethics as well. So clinic support AI, what are the tools why we are using tools? As we just touched, for the records, assessing real-time information. So we can use something called servers, online servers. Anybody knows what is an online server or offline servers, and anything about data management? So right now, many of us are using EMRs. Can you raise hands? How many of us are using EMRs in practice? Okay. I think, okay, we are adopting, but little slow. I would say pediatricians are very intelligent people, but they are literally want to be in the left side of the curve, on the Bell's curve, when it comes to learning new and adapting new technologies. So we have to move a little faster. So why data is important? Because you can access your information from anywhere. Like your mobile can access a server anywhere. You can give a prescription. You can access the records, give an advice, right? And we can automate the documentation, access real-time data, and we can also support the clinical decision making effortlessly. And what documentation tools we can use? Like there is a voice to text automation tools available. There is a handwriting to text with a Bluetooth pen automation tools available, and increases accuracy. And most of us are blessed with very bad handwriting, so we don't need to rely on handwriting, because in my practice after half an hour I can't recognize what I've written. So that is good for me because it's a boon for me. I can understand what I wrote finally. And again, the reduction of the administration problems. And marketing tools will also touch upon how we can use logos. How many use logos for their clinics? Okay, that's less so. So logos are important for branding. You see all the corporates, even all the leading brands, everywhere you see, forget about medicine, they have logos. Logos create an identity. And in these days of automation, you have lots of tools that come to them. How you can create easily logos, just give them information and then create a logo, and you can edit the logo as well. You don't need to pay designers for that anymore, frankly, because digital designer used to charge around somewhere around 2 to 20,000 rupees for logo designing. Now it's almost free. So targeted ads. You know what is a targeted ad? Anybody has done a Facebook advertisements? A paid Facebook ad portal. Are you aware of Facebook ad portals? Yes. Okay, great. So in Facebook ad portals, it comes under the section of Meta. So Meta is Facebook, Insta and WhatsApp. So what they do is it's an integrated portal. So once you need to advertise something, they have to follow certain laws, guidelines, and you have to set something like a target audience, the niche, what are the people of interests, what is the area, what is the pin code. Anybody knows how many pin codes we can put in one target audience? It is 25 as per Meta as of now, and there is a update called the Andromeda update. So you don't need to get all this clutter. The only thing you need to focus when you're doing a Facebook advertising is you just focus on your target audience and the areas and the Andromeda automatically updates your ads, right? So why it's important? Because everybody is now on Facebook, Insta, and WhatsApp. WhatsApp has certain rules. You cannot give bulk SMS. You've seen the broadcast also has changed. Have you seen your broadcast are not able to do broadcast anymore easily? Yes. So it is paid. So you have to be carefully drafting it. Many of us had this election lambo jimbo. So many of our friends' accounts are blocked. So what they did not know that Meta has rules against this unsolicited marketing, and then we can use analysis tools to see if you put an ad somewhere, how is it working? कितने लोगों को मिला, कितनों ने क्लिक किया, कितनों ने उसमें कन्वर्ट किया, कौन सी आपसे इंटरेक्शन पे आए. Anybody has a GMB? You know what is a GMB? Well, it's a Google My Business page. How many have GMBs? Okay, very less. So what you need to do, you should have active Facebook account, which should be a business page, right? You can just go to Facebook, create a page, put your business identity, and it has to be different from your personal page, right? This is to make online presence. And Google has SEO. We just started Dr. Ramas' search engine optimization. So how the SEO works? It is not only the Google, they extracts the Google, those bots. The bots track your YouTube, bots track your Facebook, bots track your LinkedIn, and also some WhatsApp and Telegram profiles. So you have to be omnipresent everywhere, right? And right now AI has made it very easy. Now we have visual tools also. Anybody has designed creatives for patient explanation in his practice? Creatives, you understand, जो आप images generate करते हो जैसे chicken pox की treatment का या ऐसे कुछ, right? So you can use AI to create visuals and even professional website layouts. There are companies like Wix and Hostinger, Durable. They just create in minutes and seconds. See, it might not be perfect. You can tweak it and then use it to make your landing page. You know how important landing page is? Anybody knows what's a landing page? How many have a website? Tell me. So again, see, we need to work on these parameters. Website is very important of your own, and it is not costly. You don't need to hire a developer. You don't need to hire a programmer. I will give you a list of tools also. You can just go there. I just listed Wix, Hostinger, and many other tools you can use just for hosting the, and hosting is also, there's a company called Shopify, Shoopy. They are pretty cheap. They have got all Google algorithms inbuilt. सिर्फ वेबसाइट बनाने से नहीं होता है, आपकी ऑनलाइन प्रेजेंस सिर्फ वेबसाइट से नहीं होती. गूगल के कीवर्ड्स होते हैं, गूगल के अंदर 10 चीजें और होती है, जैसे आपका जो ट्रैक करता है बॉट, राइट, जिसको हम Google tracks those things. So even website has to be optimized. So social media messages. So what social media marketing strategies we can use? As I enlisted lot of channels, Facebook, Insta, Meta, they can use for marketing to engage the audience, to have a targeted campaign. Suppose you want to have a ROI on something, return of investment of particular, you have a budget in mind, then how much business is coming to you, monitor the patient feedbacks. And Google also, GFB gives you an analysis, how many have reached your website, how many saw your engine, how many converted, how many came for directions, everything is available. So reputation management tools, and see how many understand that everybody is being harassed these days by false reviews or bad reviews. Anybody has experienced? I have seen Dr. Vipul has. So people, I don't know what they expect from us. We are just service providers. Somebody might not be happy and somebody might be very happy. We are doing the best we can. But this is a tool which has given authority to our patients to judge us in a very sometimes bad or sometimes very, very worst way, including, you have to, there is a complaint center. You can go on the review and you can file a complaint. Google does not remove that review, but sometimes it gets flagged and it gets on the bottom. And I'll give you a tool also where somebody is trying to write and malign your reputation in your clinic only. वो स्कैन कोड से करोगे तो वो अपने ऑटोमेटिकली 3-star रेटिंग के ऊपर ब्लॉक कर देगा. इट विल टेक टू अ डमी वेबसाइट और वहां डाल देगा. अगर वो इंटेलिजेंट है अलग बात है, बट मोस्टली वो रुक जाता है वहीं पर. सो दिस फ्रस्ट्रेशन इज गॉन. दैट वन मूवमेंट ऑफ फ्रस्ट्रेशन, यू हैव टू कंट्रोल दैट of the patient. For clinic practice, we can use multiple tools, Glass AI, Chat GPT, Deep Scribe. They are free and paid versions of all of them. They are available. It has made my practice very easy. Case synopsis, complicated cases, even when to refer, what guidelines, what treatment, what investigations. Really click of a button. All you have to give good prompts. So you don't have to be a prompt engineer. It will guide you once you have. But again, you have to use your own brains to set the algorithm right. And the other can be clinical support in decision making, I just said. And this MedGPT, Hippocratic AI, UpToDate, Elicit. There are lot of AI tools coming every day in the market, but you have to be really checking them out before using them and spending money on them. There's radiology AI. We can analyze the radiograms, and again, then these tools like Claude, ChatGPT will help you customize the educational content. Canva can do code writing also. So Canva update can do text to voice, voiceover. Lots of updates are there, and I think it's a paid version is pretty cheap for 4,000 a year. So you can use that. Amazing results, not perfect but really good. And other, you want to make some creative videos with Animaker, Cynthia, these kind of things are available. And you can use WhatsApp chatbots, video translators, other interactive tools like Google feedback forms, which is free. Quizzes, you can actually use quizzes also for Google. Even WhatsApp has a poll system now. So as I said, for marketing it's important, social media management, for SEO, the website growth, online presence, automations, the follow-ups, you can engage them for when is the next visit, when is the next vaccinations, or you have a test planned for them, something like that. Creating your own clinic or maybe your own business videos for promotions on Insta, right? The voice, you don't want to star in them, just use an avatar, right? And you can create a video, just give the instructions, and we covered that. So this is a very comprehensive topic. My job was to make it little known to you, and there's an important part of ethics, because we can face a backlash if we are really putting only the technology in and removing the human interface. So you have to balance it out. With practice, you will understand that when to use. But accept AI, accept automations, accept technology, because without that, I think we will not be able to survive long. And so things are just getting started. So you just need to improve on your knowledge. We are intelligent people. We are blessed with good brains, and I have deep regard for my community. So thing is that it can be learned. You have a lot of people around you. We have Dr. Vipul. I just told what he is to me, and me, if I can help, I'll be ready to help anybody, anytime, please. Thank you so much.
Thank you, Gagan. Gagan has given a broad view, has covered everything. My simple message is, every one of us should have a Google My Business page. Even if you don't have, some of your patient might have already made it, just claim it and start using it. Get benefited with Google algorithm. Now, what is Google algorithm? If you have a Google My page and you have a regular 1 or 2 ratings every month, and you reply to those ratings regularly, and you post 1 or 2 photos every 3-4 months, automatically your posting or your listing gets a better algorithmic rank than somebody else sitting next to you. So keep on pushing your Google My page up with regular stars, regular replies, and occasional photos to keep it up. Second is, if you are not using WhatsApp Business for your office, start using it. There are so many benefits. One is, as and when somebody puts a message onto that number, they get an automatic reply of your timings, how to take the appointment, where to go for emergency, and what are the emergency numbers of the clinic. So half of the time, the problem that you did not contact him when he was in need goes off with Google Business, WhatsApp Business. Plus, it has so many other auto replies available. You can use them. You will not have to type the complete reply. You can feed 15-20 auto replies into it. As the message comes, you can just type the code of that reply and it automatically goes. Plus, you can use that through your receptions for reminding appointments and birthdays if you want. But these two things every one of us should be using, because these days if you don't show that you are tech savvy, patients will not accept you. At least the next generation that is coming will not accept you.
Right. So you have sensitized us well. As Vipul sir also saying, it is very important to upgrade ourselves. The cheese has moved. We have to move. Otherwise we will be nowhere.
I just want to add one thing. Sir highlighted before. Target only 1 to 2 reviews a day if you want to. If you move more, Google will actually remove those reviews.
Gagan, 1 or 2 reviews a month, not even
Month
a day.
is okay, but if you want to grow, actually you want to conscious about reviews, not more 1 to 2 a day, not more than that, as per algorithm.
Gagan is the Shershah of West Delhi. Ye dil mange more. So he will never satisfy for less. Well, the take home. नहीं सर अभी क्यों जाओगे? अभी तो लंच है, उससे पहले लैंप लाइटिंग है, फिर आप दोबारा चेयर करोगे सेशन, फिर हमारे साथ फोटो खिंचवाओगे, ऐसा कैसे चले जाओगे? One thing take home message sitting on the first row since morning here is I thought कि MD pediatrics करी है, टॉप रैंक लाके हमने किला फतेह कर लिया. आज बैठ के पता लगा pediatric ENT, pediatric dermatology, ये दिल मांगे मोर. गगन साहब ने कंप्यूटर में ही फेल कर दिया. विपुल साहब कंप्यूटर एज वेल एज फाइनेंशियल मैनेजमेंट में मास्टर्स हैं. So I think it's a long way to go. We need to read more, update us, grow more. Sorry, I missed Dr. Manish Gupta sitting here. Another financial, and I mean the sessions that are to follow will humble us more to learn more and to grow more. To the chairpersons, it's a big thank you. Thank you, Gagan, and the chairpersons and the speakers to please collect the felicitation from the selfie counter. We'll now take a small break. It will be the inauguration ceremony. Post that we'll have the lucky draw, and we will continue with the sessions post the inauguration. Because of the PG poster presentation in between, it's a little inconvenient, but we will now have request everybody to move to the second audience, the second hall where the inauguration will happen. Thank you, and hoping to see you soon.
इधर आ जाएंगे प्लीज, साइड आ जाएंगे. आप इधर आ जाएंगे. तेरे को कह रहे हो तो डबल हुए इधर आ जाओ. पीछे आइए. नहीं साथ में. यस प्लीज. Yes, doctor. Thank you. Yes, video, Vika.
I request Dr. Alok Bhandari sir to please escort and felicitate our guest of honor for the day, Dr. Singara Velu sir. We all have voted for him. Can we have a big round of applause, please? Thank you so much, sir. I request Dr. Smita Mishra ma'am to please felicitate Dr. Alok Bhandari sir. He's our favorite, all-time favorite of the whole Delhi and India now. CIP OBs, EBs Dr. Mukesh Verma, Dr. Mukesh Dhalkar and Dr. Manish Gupta sir. Dr. Samarji to please felicitate Dr. Mukesh Verma. Dr. Rashmi Grover to please felicitate Dr. Manish Gupta sir. I request Dr. Prashant Seth sir to please escort Dr. Ajay Gupta sir, President-elect IIP Delhi 2026. I request Dr. Dinesh Goyal. Dr. Dinesh Goyal sir. Dr. Samarji, please felicitate Dr. Dinesh Goyal. We have some special guests with us. Dr. Anita Sharma ma'am, mathematician, senior mathematician, principal from CBSE.
Anita ma'am is close associate with IAP and she is NCRT member. So new education policy modulation, she is also part of that group who made it. And she is educationist, retired principal, but is still on the run all the time, flying from here to there across the India. And I am very lucky that I got her over here. Thank you. The topic of June meeting was child literacy and CBSE curriculum.
विशेष जाड्या पहा शुक्लां ब्रह्मविचारसा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीमभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता
ये एनर्जी मुझे पता कहां से आ रही है, अपने किड्स के लिए। सुपर, यस, तालियों के सलाम आना चाहिए। Come on, everybody, and sing together. वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु
बेटे पीडियाट्रिक कार्डियोलॉजिस्ट हैं और उनकी बहू भी इतने दोनों इतने ज़्यादा टैलेंटेड हैं एंड वी रियली वांट कि एवरी सन एंड डॉटर ऑफ द एवरी। नाम है मीना, डॉक्टर मीना, जो कि बहुत ही स्माइलिंग और अभी तो बहुत रिलैक्स भी लगने में। एंड ये जो हमने अभी IAP एंथम गाया, ये कॉन्सेप्ट उधर से आया और लिखा मैंने, क्योंकि मैं यहाँ पे ज़्यादा कुछ बोलना नहीं चाहती हूँ एज ए प्रेसिडेंट दो दे। आई थिंक शी हैज ए वेरी गुड रिपोर्ट फॉर द ब्रांच एंड आई थिंक एवरीवेयर सेम। इवन राधिका का पर्सनल भी फ्रेंड ग्रुप है जो हमेशा यहाँ पे होता है।
That it will take a little time, but I'll try to be fast. I would like to begin my report by expressing the IIP West Delhi City Branch reported on its activities and leadership from January 2025 onwards, emphasizing Child Week 2025 at Radisson Blu Dwarka. The event was graced by distinguished academician Professor Dr. Dheeraj Shah, Director of the National Institute, Guest of Honor. In respect to memory of Dr. Devendra Gaba, who passed away on January, shape and strengthen our branch over the years. We deeply appreciate and commend these outstanding leaders. Those championed by our President, Dr. Smita Mishra ma'am. Her tireless dedication, especially in advocating for the inclusion of cardiac ailments under the thanks CIP for its unwavering commitment to child health literacy program, especially for class 7th and 8th grade children, as she educator, mathematician and member of NCRT, recognized for her expertise in educational policy. The meeting brought together a classroom teaching program at SDPS school where Dr. Anita was principal there. Welcome Dr. Anita ma'am. CIP anemia prevention program, the Bye Anemia, was conducted at 6 centers across West Delhi and Shadra by our ED members with improving the nutritional standards of the kitchen. So we had a full day anemia program at the park with these children where we educated, and yoga day on 21st June at Vegas Mall. Initiative for Down syndrome babies. With various hospitals of the nearby area, we collaborated with the Pediatric Association of Dwarka Max Health. Yogesh Parekh sir.
All respected seniors and dear colleagues, first of all, congratulations to West Delhi IIP, Dr. Rita Madam, Dr. Radhika and Dr. Samarji for the wonderful, this extensive, elaborative West Delhi annual report. खत्म ही नहीं हो रहा था मैडम, आई एम वेटिंग, इतना सारा एक्टिविटी।
बेस्ट प्लान अवार्ड अनाउंस कर दो, नंबर 1 पर। यस कर दो सर।
दिल्ली वाले तो दिल वाले हैं, वो मांगे बोर बराबर है, हर बार मेरे से कुछ ना कुछ अनाउंसमेंट करवाते हैं। Yeah, no issue. I am coming to the point, madam. Dr. Smita Mishra madam has called me several times to upload this annual report on the portal, our website portal, and she has worked lot of with the support of the technical person, and she tried to miss रात को लेट तक सर डेडलाइन खत्म हो रहा है, मैं कोशिश कर रही नहीं हो रहा है, some technical glitch है, but she was very passionate to push, कि मेरे को करना ही है, और मैडम had did it. हो गया ना मैडम लास्ट में, अभी आज भी है एक्सटेंशन।
IIP Delhi got the best state branch award in 2020 when I was the president. She was the secretary. She was very hardworking.
स्पेशल अवार्ड डॉक्टर भंडारी के टाइम पे भी और डॉक्टर मुकेश धनखड़ के टाइम पे भी दिया है, पूछो तो। So thank you very much for the inviting. It is your love, affection. मैडम ने, स्मिता मैडम ने कॉल किया, और all of you know, somebody is my classmate, MBBS. So because my elder son is pursuing the internship and he came to home this weekend. He was not came in the दीपावली के टाइम पे वो नहीं आया था।
विद्यार्थी को आप लैंप राइटिंग के लिए वहाँ खड़ा कर देंगे ना, वो बोलेंगे मैं तो नहीं करूँगा जब तक बच्चे नहीं होंगे मेरे साथ।
So that is the beauty. And other thing I noticed mentioned about the Dr. कैलाश सत्यार्थी, जो बुक्स दिया है, सबको हिंदी वेलकम.
Thank you, our National Treasurer, Alok Bhandari sir, for your nice introduction. Namaste. A big thanks to every one of IAPNs for giving me this wonderful opportunity from the remote part of the south end of the country of India, that is Tamil Nadu. That too, always India is referred as Kashmir to Kanyakumari. Just 200 kilometers short of Kanyakumari, where my place. So I come all the way from that. I can remember each and every one of you, the love and affection you all showed to me during my campaigning, not only during my campaigning, when I was Vice President in 2024, along with my mentor and Senior Vice President, Professor Satish Sharma ji, and we had a wonderful tenure at the time where we were invited first after taking over Delhi. Alok Bhandari ji was the president. We had a wonderful initiative at that time. People told that I should become president, which happened today. It is all because of you. So again, after got the result, as a humble IAPN, I come here on your request because I sentimentally, though many conferences they invited. So after assuming Vice President came to Delhi, after being elected when Delhi invited, I wanted to be here. Thank you, Madam Smita, for giving me, because she is a good friend of my son being a pediatric cardiologist and ably supported by very dynamic. I could really wonder the way you are doing the community service in the aim of the country. I really hats off to the team because all the support given by all the elders, senior presidents, so the tradition, hierarchy is being very well maintained. Hats off to you, ably supported by Treasurer, who is our chief guest, HSG's classmate. He always used to tell, my good friend Alok Bhandari, and our dynamic Secretary of State branch, Shamina, who always encourages me. And if I start mentioning each and every one of you, most of them I know because I have troubled you. Because I came 3-4 conferences to Delhi, I met each and every one of you. If I do not take much of your time by mentioning each and every one of you, starting from my mentor, my Senior Vice President, a medical legal person and elected medical chairperson, Satish Sharma, Mrs. Anita Sharma, and our EB colleagues, Lalit is there, and present EB member Manish is there, Mukesh Dhankar, and other EB colleague S. Bushit is there, and so many people, each and every one I can tell by name, but want of time I won't take each and every one name. It means that whatever speak it is, or it includes all of you. Having given this opportunity, as I mentioned everywhere, championing the cause of every IAPN. That is my motto when, as a presidential candidate, I declared this. You know, those who have received my visiting card, it will be in the top of the line. We talk about community. Yes, I am a Rotarian. I am a AMA person. I do lot of charity community work in my place where I have received so many awards, which I don't want to talk much about me, all about within my state. Now you have gave me the opportunity to serve our national AP as a pan-India person. Definitely, I will try to do my best to live up to your expectation. Why I bother about IAPN first? Unless in the present era, where lot of one-end medical legal issues. Second, mental issues. Third, financial problem for young pediatricians. And so many rules and regulations, and where community is their so-called noble profession. When I started my journey, people were falling at my feet when served. Now the respect is day by day is losing. Community times are changing. In this present era, we have to take care of our own members. The organization should take care of each every one of IAPN. Then only people have faith. During my campaign the entire year, I traveled the length and breadth of the country, starting from north to south, east to west. I could feel the pulse of each and every young as well as senior pediatrician. People who are young, not bothered about IAP, they are asked what IAP is going to do for me. So, lot of things has to be taken, which we have to. I don't say that I can change everything, but we should try to make a change. Everybody, our past leaders have done the best, doing the best. We will try to do something different. So what way I want to be different? I am available 24/7, anytime, any call. My phone will be never switched off. Second, I don't want any prizes, but I need criticism. If you are a true IAP, you want to do something to IAP, please come up with your suggestions. Feel free to write to me. Send messages. Don't need to prize. But if I err anywhere during my tenure as a president, whatever our team does, it reflects only onto the president. So you can feel free to call me, openly criticize me. I don't have any egos. In my life, I never, because I held several posts. I always think when I occupy the post, it is like wearing a new shirt. At the end of the day, we remove the shirt. So as far as in the post, I consider, but I should maintain the dignity, decorum, everything. Definitely, I will try to do my level best. But at the same time, a lot of seniors are here. I know Kiran ma'am and all others are there who are really committed to community, social. So you have more rich experience because you are in the head of our India. So you can come with new innovative ideas, what we can be implemented. Please give those suggestions to me. Be with our team, try to do what best I can. So with this, I thank the team West Delhi for the wonderful work they are doing, and a lot of seniors. Really great thing that I've been today with you all too. So I can take it as a thanksgiving for the wonderful support. Once the elections are over, we are not talking. I am not going to do the post-mortem analysis, who supported me, who are not supported me. It is not that. People have faith on us, gave the post. I should live up to expectations of each and every one of the IAP. That is I try my level best. What the trust people have, a person without having any big leaders to support me in my candidature in my state. But my state, I was able to brought to unity. In that way, from where I was hailing, my state had a big unity, which I wanted to bring that unity, expand the unity to pan-India, so that as IAPN, we should not only be academician, good administration, good community, social, whatnot. Everything will be done, and I need your guidance. So with this, I thank each every one of you again for giving me this wonderful opportunity to thank you en masse, because it is very difficult to meet each and every one of you. So please spread the word of thanks to your all the 5 zones of Delhi and beyond that for giving me this opportunity. Thank you, thank you. Jai Hind, Jai Hind.
Shortly and gradually let's increase our bridges with the North India, the Hindi heartland should be one, and we have to increase our strength to take it to logical end. Thank you, please. Thank you.
Thank you so much, sir. With this, we come to the end of the inauguration ceremony. Thank you so much, our dignitaries and all the guests. Now the sessions will continue with the running lunch. And thank you all from the core of my heart who have come here to attend the conference, grace this occasion. And I assure you that you will not be bored with my WhatsApp messages for next 1 week. Thank you so much.
Actually, if you are worried about, it is like कोरोना हो जाए कोई बात नहीं, सीवियर नहीं होना चाहिए. सिमिलर इज द केस है. डेंगू हो जाए कोई बात नहीं, सीवियर नहीं होना चाहिए. तो डेंगी, सीवियर डेंगी से प्रोटेक्शन एफिकेसी वाज 86% at the end of 4.5 years in seropositive baseline group, and seronegative baseline group it was 80%. Coming to the third part, that is talking about all the serotypes, because it has to be against all the serotypes. That is very, very important. It was found that the vaccine works best against DenV2. That is the most prevalent in our country and across the globe also. Seconded by DenV1. Vaccine efficacy falls down to 40s, reaching up to 50s regarding 3 and 4. So the efficacy against 3 and 4 is also good, but it has been historically seen that you are not having lot of 3. So the studies are ongoing for DenV 3 and 4 also, but as of now, at the end of 4.5 years, the efficacy is still around 50%. So a good data, and the studies are going on for 3 and 4. Talking of seropositive, the vaccine works well for all the 4 serotypes. In seronegative baseline individuals, 3 and 4 data is still to be presented, as the number of candidates are something which which can happen at different parts. You can have the vocal tics, you can have the motor tics on the part, and the most important part is that if you ask him, if you counter him, he can stop it for a while, and maybe after a while he starts doing these movements again in the part. Most of the tics, they don't require the medications. Tics have got a vaccine any kind of phenomena, and you have to educate them, you have to let them know that there are hardly serious underlying neurological causes for the tics in that way, and if they require medication because it is kind of like socially or troubling them, you can think medications like clonidine. I use Arkamine a lot because a lot of these kids has got this ADA genetic. It can be structural again affecting the vidya ganglia on the part. We don't see so many of Sydenham's chorea these days, but still we've got a couple of patients which are coming almost a year. We see 1 case on the part. So chorea is dance-like, which we have been reading through our MBBS did. But what I find practically useful is this dance-like is an untrained dance-like. This is not rhythmic on the part. You'll just find that the hands are moving like this. Hands are moving like this. It's not like a very synchronized kind of movement. So this is dance-like, but practically I find this is wise to understand that this is an untrained dance-like movement, which you can call them chorea. Last 1 or 2 I'll just show you. Dystonia is a kind of like sustained posture. Look at this child, don't require video. Look at the child, how the hand has been kept. Both the agonist and the antagonist are working at the same time. This is like a twisting posture on the part. You don't require the video, only the photo will be helpful to see. Okay, this is a kind of like a twisting posture on the part. This is dystonia, Again, it can be kind of because of some structural pathology affecting the basal ganglia. It can be because of your DOPA-responsive dystonia, those kinds of phenomena in that way. Again, a child with the brain iron accumulation having the posture of twisting posture. So dystonia, the drug of choice is levodopa. You can start with that part, and then you got other drugs like trihexyphenidyl, gabapentin. Benzodiazepine works a lot. We get a lot of cases with the cardiac tethers having the severe dystonia. You can think of starting them on the benzodiazepines because that works in these cases quite well on the part. Twisted movement is classical for the dystonia. The parents will tell you that the child remains totally twisted. I mean, you can't keep him in the lap also on the part. This is classical for the dystonia in those cases. They all have in the spectrum. Chorea is much more faster. Dystonia is slower because they all involve your basal ganglia only. Maybe look at this child. He is walking unsteady. He can't walk steady in that way. He requires some support also in that way. Fine. This is ataxia, when you have got this incoordination of movement. The movement is incoordination, and that can be there in all the, I'll just take maybe 2 minutes more. Incoordination can be there at all the places. You can have incoordination of eye movement, you get the nystagmus. Incoordination of speech, you get the slurred speech in ataxia. Incoordination of hands, you get the finger nose test incoordinated. Incoordination of gait involves with your kind of like ataxic gait on the part. And for that required that you're starting from the vision is intact or not, the power is intact or not, because these all are required for a coordinated movement, and then the sensory and again your cerebellum to be looked for on the part. So ataxia is about the incoordination. So yeah, I'll just skip this one. This is the last one. So these are the kind of movements which you normally see, but you can also have movements which are not like a typical movement. So like look at this child, he's also having some kind of bizarre movement. This is a non-pattern movement. He's doing something, but they are not kind of like explainable on the part. Bizarre pattern, acute explosive. He was well a day before, now start having all these kinds of movement. It does when people are around, and it's not falling from that 2 feet kind of like couch also on the part. So this is like a functional movement disorder on the part. We don't call them psychological, we call them functional, because you'll find that they still have got some amount of functional neuroanatomical defect in the brain. Nowadays they are doing the functional MRI and they are finding that even these kids have got abnormalities in the functional aspect of the brain. Their cortex, the basal ganglia are highly interconnected. That is why, and their limbic system, that is why they are much more labile to emotional stress, and that manifests with a different kind of your movement disorder. They also have got kind of like functional disorder on the part, and that's why we call them, this is not malingering, this is also a true all movements. Seizures are always brief. They won't be happening for like 5 minutes, 10 minutes, 15 minutes duration on the part. And second is post-event. Seizures will leave some mark after the event. Child will become drowsy, sleepier, lethargic on the part. But these movement disorders, they don't have kind of like post-event on the part. These two things will tell you this is not a seizure, this is something like a movement disorder, and then you can decide this is hyper or which kind of movement disorder on the part. Thank you very much.
Especially with the videos. I mean, couple of points that I want to make is, often we are confused when we are assessing hypertonia, whether it is spasticity or dystonia, what it is. So, spasticity is more to be felt. When you examine the child, you feel the movement across the joint, and it is a velocity dependent movement, we all know. So, spasticity is more to be felt, and dystonia is more to be seen. So, without touching the child, you will see dystonia very apparent. So, this is a good way to differentiate between spasticity and dystonia, and after they occur together. And the second thing I wanted to highlight was for tics disorder, because the topic was tics, that often it goes on for months, and then it's called Tourette syndrome if it goes for 12 months. So please, there is always this caveat of child suffering with depression and rage and aggressive disorder. So please do refer them to pediatric neurologists and psychologists, because there will be underlying rage and aggression with depression if the tic disorder has gone on for long. And lastly, I want to mention DOPA responsive dystonia, that's our goal. That if you see a child who presents with dystonic cerebral palsy, and there is some posturing of lower limb, some posturing of upper limb, but there is no history of birth asphyxia. There is MRI is more or less normal. Then please don't be afraid in prescribing levodopa. It works like magic. It is magical. The very next day the child will be better, significantly improved, and the family will thank you. So please, if you see a child with dystonic cerebral palsy without history of birth asphyxia or any other evidence of birth asphyxia, do give a trial of levodopa. The family will be thanking you a lot.
Thank you.
Nice to